enlightening us on this important topic of COVID.
No
We
worries.
see, these days, I was just discussing today also, many patients of COVID, when they need admissions in the hospital, severe COVID. So generally what we are practicing is that all of these patients are basically put on antibiotics, the host, multiple antibiotics in generally. So I was just thinking, is it really required? Do we have some kind of guidelines, some parameters to really suspect who are the patients who may be having secondary infections where the antibiotics definitely would be of help? Or do all patients require cocktail of antibiotics right in the beginning? So I think this is the area which I think you both kindly just highlight. I was just wondering if you can take the help of biomarkers like procalcitonin. Will it help in stratifying patients actually who would be requiring and benefiting rather than using antibiotics in all patients?
Well, I'm sure, I think Anubhav will touch base.
Yeah, I will touch base on that thing.
But just candidly, in our experience, the rate of secondary infection has been less than 10% in all our population. So our practice in the beginning, it was similar in a way. We were using a lot of these empiric antibiotics, but towards the tail end of pandemic here, I think we stopped using secondary infections coverage empirically, and it was case by case basis. But I'm sure Anubhav will talk a little bit more about that.
Okay, I think we can have a discussion at the end. Let's hear Anubhav.
I think we'll have a Q&A in the end. That would be even more informative, asking just the way you ask questions. And again, we'll just share our experiences, and it's more like what is right, what is wrong. It's learning from each other's experiences. So absolutely.
So I think it's 9 a.m. my time, and I think it's 6:33. Maybe we could wait 2 or 3 more minutes, and then we can get started.
Good evening, everybody. This is Dharminder Kumar, Assistant Training Coordinator of H&FW Parimal and host of today's meeting. I welcome you all today's webinar. Today we have with us Dr. Anubhav Kanwar, MD, and Dr. Himanshu Bhardwaj. Before I call Anubhav Kanwar sir for presentation, I would request to worthy principal of State Institute of Health and Family Welfare to welcome these two resource persons to today's speaker and address the meeting. So kindly unmute yourself, ma'am. With these words, I hand over the mic to you. Kindly address the meeting and welcome today's resource person. Thank you very much, ma'am.
Okay, thank you. Good afternoon, everybody. So I welcome all of you for this today's webinar. Today's first topic is the COVID-19 and infectious disease perspective by Dr. Anubhav Kanwar, MD, USA. And the second topic will be COVID-19 respiratory failure, first for management of the disease. This is by Dr. Himanshu Bhardwaj, he's MD. So I welcome you, sir, and I hand over the mic to you. You can please start your presentation. Thank you.
Thank you, Dr. Kaur. This is Dr. Anubhav Kanwar. I hope I am audible and
Yes.
my presentation is visible.
Yes.
It's a privilege and an honor to connect with my alma mater and all the physicians in Himachal Pradesh. I think this is a tough time for all of us. We are at the tail end of the pandemic in the US, but still, my whole family is in India, and I really share the pain and the things which are going on. And I think this is the time we can come on together to help each other to navigate this difficult time. So with this quick background, I will get started with my presentation. So COVID-19 and infectious disease perspective. So the objectives of my talk are: one is to describe the pathogenesis and spectrum of disease in COVID-19, to lay out key principles of management of COVID-19 and prevention, to share my experience managing COVID-19 patients in a 220-bed community hospital in the US, and lastly, discuss potential ways for telemedicine consultation by IGMC alumni in the US for physicians in Himachal Pradesh. My talk is outlined as follows. I will be discussing some key facts. I also call this as my summary slide. I will share it in the beginning and in the end, kind of reiterating key facts that we should always remember. Briefly touch base on pathogenesis, clinical manifestations, management of COVID-19 in home setting, ED setting, hospital setting, and last but not most important thing of this topic, which is how we can prevent COVID-19.
Excuse me, sir, can you share your full screen?
All right.
Please place your presentation at slideshow mode. Okay, thank you.
Is it okay?
Yes, yes.
So the key facts. So the COVID-19 is caused by the human SARS coronavirus 2. We really do not know what's the reservoir. The closest known relative is a bat coronavirus called RATG13, which was isolated from a bat in southern China. It matched about 96% when we compared the DNA and the other genetic material of the virus. So we really do not know. There are multiple hypotheses that it could have escaped from a lab, it could have been introduced. We really do not know much at this stage, but we do know that these coronaviruses are bat coronaviruses, and due to ongoing changes with more human to animal interactions, these viruses are jumping from one species to the other, and in the species they evolve, as we see with COVID variants, leading to a worse or a more lethal virus. The transmission of COVID-19 or SARS coronavirus 2 is through airborne, which is, I would say, and droplets, which is the main mode of transmission. And then to some extent, there is some contact transmission which goes on. The incubation period is 2 to 14 days, but on average, it's around 5 to 6 days. The treatment is antivirals and monoclonal antibodies in the early disease and steroids in the late disease. And then prevention of COVID-19 involves vaccination, universal use of face masks, physical distancing, avoiding indoor and crowded outdoor settings, hand hygiene, and increased testing. So this summary slide, I'm going to go in detail of these points, but kind of setting the flavor up, I wanted to share it up front. So what's the pathogenesis? How does this virus get into our body? How does this infect our cells? I think it's very important to understand this as doctors. We need to know these things and kind of use this information in managing our patients in prevention of COVID-19. So the first step is that SARS coronavirus 2 is present in the surroundings, be it air or the droplets or surfaces. From there, it gets entry into our body, and I would share what parts or what are the portals of entry where it gets into the body. So when it gets in, it basically uses the ACE2 receptors, which are in our nose, which are in our lungs, our GI tract, our other parts of like kidneys, cerebellum, brain. And so from there, it attaches to the ACE2 receptor. And then there is a protein called the TMPRSS2, which helps with the activation of the S protein or the spike protein, and it facilitates the viral binding to the host cell membrane. The cell enters the host cell, the virus enters the host cell, and then it releases its RNA, uses all the machinery to replicate itself and assemble more virions. Once infected, it can create hundreds of new virions, which leads to rapid progression of the infection. So that's step number one. Step number two is that the virus, when it has already entered the cells, it elicits the inflammatory response. And as you can see in this picture, we have a cross-section of the alveolus. So we can see, it is infecting the type 1, the type 2 pneumocytes. And then it's leading to the activation of the inflammation pathways where we see aggregation of neutrophils, monocytes, T lymphocytes. These inflammatory cells release cytokines such as TNF-alpha, IL-1, IL-6, which basically act to recruit more inflammatory cells, but also cause some collateral damage. And that basically is what we see in the later stages of COVID-19, as highlighted in this slide, where we see increased vascular permeability and then leaking of this fluid into the alveoli, leading to the non-cardiogenic pulmonary edema. There is a sequelae of the damage, which is the hyaline membrane formation, and then it also activates the coagulation cascade, leading to microthrombi, which leads to blockage. And I think that's basically what's causing the VQ, or the ventilation perfusion mismatch. And I think Dr. Himanshu will touch base later on how proning could help with this VQ mismatch. But this is how that pathogenesis of COVID-19. I think if we were to take some key takeaways from these three slides, so there are two main processes. Early in the clinical course, the disease is primarily driven by the replication of the virus. The virus is replicating and it's leading to symptoms, as we see, like fever. When it infects the olfactory area, it leads to anosmia. It affects the receptors in the brain, governing the taste sensation. It leads to dysgeusia, the taste alteration, and other symptoms. But later in the clinical course, the disease appears to be driven by a dysregulated immune and inflammatory response, which leads to tissue damage. And I think we've seen in the slides, cytokines like interleukin-6, TNF-alpha, those are the key ones which cause this damage. I think to a certain point, our inflammation is under control, where it tries to contain the virus, but it's the dysregulated immune response or inflammatory response, which I think leads to high mortality that we have seen with COVID-19. So I think based on this pathogenesis, it's anticipated that antiviral therapies, they have the greatest effect when we use them early in the disease. So we have seen like medications like Remdesivir, Fevipravid, they're more effective in mild to moderate COVID-19, while the immunosuppressive anti-inflammatory therapies are more likely to be beneficial in later stages when there is dysregulated immune response. And we have seen that with medications like steroids, tocilizumab, and other monoclonal antibodies. So since I am discussing pathogenesis, I think it's very important to discuss about variants, because the mutations that have taken place in the spike protein or other parts of the virus, they have probably fueled increased transmission, higher infectiousness, and then also to, in some extent, have impaired the effectiveness of medications like monoclonal antibodies. So there are 4 major variants circulating right now. I think in India, I will get on to that on the next slide. There are different set of variants which are more important, but globally this is the variant, the B117, first noted in the UK. There is B1351 noticed in South Africa, the P1 variant from Brazil, and then the variant which was first detected in India was the B1617, also called as double mutants. As you can see, I have highlighted the mutations that have taken place in the spike proteins. I think the main concerns with these variants is one, transmissibility. So the variants B117 and B1351, they are more infectious and more transmissible. And we have seen that with kind of the outbreaks in those countries. There is also concern about increasing severity of illness. So the B117 is more virulent, and we have seen higher mortality rates with this virus variant. There is concern that the vaccine efficacy is also affected. I think the data so far is promising. It does say that the vaccines are able to neutralize these variants, but still it is to a lesser extent compared to the natural virus or the wild type virus which was circulating before. I think there is not much data on the Indian variant, the B1617. There are preliminary reports from ICMR that the Covaxin is able to neutralize this variant, which I think is promising. But I think this is a moving target, and we need to get ahead of this virus by vaccinating large chunks of our population before this virus is allowed to evolve to a more dangerous variant. So this is a slide from the INSACOG, which is the Indian SARS coronavirus 2 Consortium on Genomics. They actually looked at 15,000 samples from January 1st till April 4th. As you can see in the red, the B1617 variant, which was first detected in Maharashtra, was very small, but lately in April and I think in May, it is basically the most commonly detected variant in India. And the second most important one is the B117, which is a UK variant. We have seen that mainly circulating in Punjab and northern India, even in Delhi. But lately, again, it is being overtaken by the B1617 variant. It still remains the very common variant in North India compared to B1617, which is mainly seen in Western Maharashtra initially and now expanding pan-India. The third most common variant found in the analysis was B1618. This is a new variant. We haven't seen much reports about that in media and in the news, but this is what was first noticed in Bengal. So when Bengal elections were going on, this was a variant which was found. It is now also becoming, as you can see in the blue, it is becoming more and more common. So these were the three most common variants we have seen. I think if we have ability to analyze more samples, I'm sure we would be able to detect more variants. I think this information is very critical in our response to COVID-19 from a public health or from a medical standpoint. So quickly touching base on where is the distribution of ACE2 receptors. And I think this slide is important to understand before we go on to describe what are the symptoms, because we can easily understand what are the symptoms of COVID-19 if we knew where the ACE2 receptors were expressed, because that's where the virus goes and it causes damage. So it's, the viruses, the ACE2 receptors expressed in the central nervous system, its upper airways, the ciliated epithelial cells, the vasculature, the endothelial cells, in the lungs, the type 2 pneumocytes, in the liver, also in the eyes, in heart, in kidneys, and the gut. So if we go on to the next slide, it kind of looks at if we apply this ACE2 receptor model to the pathogenesis. So we can see the virus enters the nose, and from the nose, it goes to the olfactory epithelium, and from there, it goes to the olfactory bulb and olfactory nerve, and it causes damage leading to the classical symptoms of anosmia. If we apply the pathogenesis slide and the ACE2 receptor slide to the whole body, we can come up with all the symptoms of COVID-19, which we use to screen or diagnose our patient. So in the nose, it can cause sinusitis, in rhinitis, anosmia. It can cause pain in the pharynx or sore throat, rhinorrhea. It can cause taste alterations. In the lungs, it can cause cough, dyspnea, chest pain, which can lead to pneumonia and ARDS. In heart, it can cause arrhythmias. It can cause chest pain. Again, those microthrombi, if they happen in the coronary vasculature. It can lead to systemic symptoms like fever, malaise, fatigue, chills, which is due to release of cytokines like TNF-alpha, interleukin-1. Neurologically, it can lead to dizziness, headache, impaired consciousness. It can lead to myalgias, and it can lead to digestive symptoms like diarrhea, nausea, vomiting, and abdominal pain. So how to manage COVID-19? I think it involves intervention at multiple steps. I will just go step by step. So I think the step one is testing. I'm not going to go much into detail of testing because I think it's very important to follow India-specific protocols. These are different from what we use in the US. I have highlighted in red in below the link from ICMR, which was updated on 4th of May, which talks about the COVID testing strategy in India. But I think if we were to summarize it, there are two main types of tests. One are the nucleic acid amplification tests, of which RT-PCR is the example. There are, I think, hassles. I was in India until April 27th. I returned on April 28th. So I had to get myself COVID tested so I could see the wait times. And I think it is very disheartening, because then for both doctors and the patients, because we're waiting for this test to come back, and you cannot like start treatment or do other things. So I think if we had more platforms where we could have like point of care PCR tests, I think it would be a game changer. There is more availability of antigen-based tests. I think they are point of care, they are low cost. There is some concerns about sensitivity and specificity, but I think when we apply these tests to a population which has high incidence and prevalence of COVID-19, these tests are equally good as the PCR test. And I think the latest strategy from the ICMR reflects that if you are positive on an antigen-based test, you do not need to get confirmed with a PCR-based test. Now, if an antigen-based test is negative and you are still suspicious about COVID-19, then it makes sense to confirm it with an RT-PCR. I think this antigen-based testing, they could be employed in hospitals, in the ED, where you can get the results very quickly, and it can help with rapid triage and isolation and starting the treatment in patients. So step 2 is to classify the patient who has a positive test based on the severity. So there are 5 main categories. So one is the asymptomatic or the pre-symptomatic. So asymptomatic is a positive test but has no symptoms. Pre-symptomatic is basically same as asymptomatic, but these are the individuals who develop symptoms later on, but they were asymptomatic at the time of testing. I think as a category, this is very important. And I think in the US, we have seen up to 40% of transmission happening from people who have been asymptomatic or pre-symptomatic. So again, I think it highlights if we come across patients or contacts of patients who have been hospitalized with COVID-19 who are asymptomatic, these people should do due diligence. They should isolate themselves so that they do not spread the virus to the others. The second category is mild COVID-19, which I highlighted the symptoms on the previous slide. So if you have any of those symptoms, but without any dyspnea and or abnormal chest imaging. The moderate COVID-19 is if you have evidence of low respiratory disease during your clinical assessment or imaging. So if someone is breathing very fast, like tachypnea, respiratory rate more than 40, or if someone is short of breath, but their oxygen saturation is more than 94% on room air at sea level. So that would be moderate category. Then there is severe category where you have the oxygen saturation less than 94% at sea level, or a patient who has a breathing rate of more than 30 per minute, or if their PaO2 over FiO2 ratio is less than 300, or if their lung infiltrates is more than 50% on chest X-ray or CT. I think this category is very, very important for physicians for triage, because these people can deteriorate very quickly and progress to ARDS or septic shock or multi-organ failure. And then critical is when you have any of that, if you have respiratory failure, septic shock, and or multi-organ dysfunction. I think the criteria for these categories are they may overlap and then they can vary across clinical guidelines. So I think that's one thing to keep in mind, that this is a moving target. So a patient who is moderate can become severe and then can become critical. We have seen that about 10% of patients who were asymptomatic, they actually progress to severe or critical category over next 2 to 3 weeks. So I think it's very, very important to have a follow-up, especially for patients who are at home, like who are asymptomatic or who have mild disease, without any shortness of breath. So step 3 is to, triage these people based on severity. So, I think it's good to have home-based care for people who are asymptomatic. who are mild to moderate disease, but not requiring any hospitalization. And then hospitalization, certainly for people who are severe and critical, but I think the patients are still having a non-COVID-19 related emergencies like, MI, myocardial infarction, or if they have like GI bleeding, which may need hospitalization for non-COVID reasons. And then I think for lack of, there is not enough beds. And I think if a state like New York or a city like New York City, where there are many hospitals, the COVID-19 brought them to their knees last year because of a sudden surge in COVID-19 patients. So I think in India, we have much less beds, much less hospitals and healthcare facilities. So I think our goal should be to identify individuals with mild to moderate disease who are at high risk for progression to severe disease, and to initiate treatments which are approved for prevention of the progression to severe COVID-19. And I will touch base on these treatments in next few slides. So how do we envision a simple triage system for our patients? I'm sure there must be something in IGMC and other healthcare facilities in Himachal. This is just my experience here in the US on how we did with triaged patients. I haven't included all details, but simple 4-step process. So first is we need to communicate with patients before they arrive in the hospital. It's good to, I think the way we did here was to have a hotline, and I'm sure there are numbers, elsewhere also where patients can call or text before heading to the hospital. This allows to triage them. Can you hear me? Hello?
Yes, sir. Yes, sir.
Yeah, I saw that I was muted.
Yeah, you are audible, sir.
Okay. So the first thing is to communicate with patients. So I think it's good to have a hotline. It could be staffed by a doctor or a nurse or a resident, and they could be given a list of symptoms. So if a patient calls that I have this symptom, for example, say I have shortness of breath, you can ask them to check their pulse ox. So if it's less than 94%, you can ask them to come to the hospital. Versus if they don't have dyspnea, you can share about managing them at home with telemedicine follow-up. The second thing is to set up and equip a triage area. So I think we need to have a separate area where patients who are coming to the ED who have symptoms suggestive of COVID-19 are coming, versus other patients who do not have COVID-19 symptoms. So it's important to limit point of entry for patients with COVID-19 symptoms and directing them to a designated area. It's good to practice universal masking, hand hygiene, PPE, have dedicated hospital staff for testing and treatment, dedicated hospital staff for COVID-19 triage versus non-COVID-19 patients would ensure no transmission between patients or from one suspected COVID-19 area to the non-suspected COVID-19 patients who do not have COVID-19 symptoms. So a well-ventilated area, these patients can go there. I think it's good to have some physical distancing. I think in Shimla and IGMC, there are issues with concerns from space standpoint. So I think we'll have to, or I'm sure there is already a process in that direction where a separate area, maybe a makeshift tent or a makeshift area where these people can come and then they can be tried safely into hospital versus back to home. And lastly, I think it's important to have that area cleaned twice daily with 0.1% chlorine. The role of surfaces in transmission of COVID-19 is there. It's not as strong as is for air and airborne and droplet transmission, but it's still there. So I think it's very important to have the disinfection of surfaces twice a day in the areas where patients with COVID-19 are housed. I think it's important to limit the family members. We had a family member restriction policy in our hospital where when we had a COVID-19 surge, no family members was allowed to visit patients. and they could only touch base through FaceTime or through WhatsApp or other methods. And I think if we have the ability to have the rapid antigen test available, we could use it to triage patients with suspected symptoms quickly, whether they are positive or negative. So with this, I move to the next slide, where I talk about the treatment. This is from the National Institute of Health guidelines, where they prescribe treatment according to disease severity. So patients who are not hospitalized and who have mild to moderate COVID-19, they could be managed symptomatically at home. I would throw light more on that, but I want to highlight the antibody, the monoclonal antibody combination called the Remap plus Imdivimab, which is highlighted with a red arrow. This is one of the monoclonal antibodies which is now available in India. Roche, I think the company which makes it, and Cipla, they have a partnership, and this is going to be available in India. And I think it will be a game changer because we have seen that these monoclonal antibodies they have played a very critical role in prevention of progressing the disease from mild to severe disease, especially in patients who are at very high risk, like people with diabetes, people who are immunocompromised, and so forth. So for people who are hospitalized but not requiring oxygen, there is insufficient data to recommend for or against the use of Remdesivir, and certainly there is no role of steroids in these patients. Then there are patients who are hospitalized and they require supplemental oxygen. So the NIH recommends that we use Remdesivir for patients who require minimal supplemental oxygen. There is role of steroids in such patients, especially who are requiring more oxygen, like was on 4 liters in the morning, say on 6 in the evening, and 10 liters on next day. So people with increasing amounts of supplemental oxygen, there's role of dexamethasone. And then when there is no, like Remdesivir is not available, dexamethasone could also be used. I think the role of this combination, it's very important to tease out the pathophysiology behind it. So dexamethasone is the anti-inflammatory, Remdesivir is the antiviral. So in the early disease, we need to address both things. In early disease, it's mainly the viral replication. So antivirals could have possible role there. In the later disease, it's the inflammation. So when patients who are hospitalized and require supplemental oxygen, I think that's the time where we need to use these both medications. Once patient goes on to a high flow device or say is on BiPAP, then I think it becomes challenging. There is no role of Remdesivir for those patients, and the mainstay of treatment is dexamethasone or its equivalents. So like prednisone, methylprednisone, and Dr. Bhardwaj will touch base on the steroid dosing and the steroid equivalents. There is some role of tocilizumab. I will touch base that in next few slides, especially in patients who have rapidly deterioration and who have evidence of systemic inflammation. For example, CRP more than 75 or ferritin more than 500. So there are set criteria, and I will discuss that later on where tocilizumab has been shown to be beneficial and reducing mortality. And lastly are the patients who are ventilated or who are on the ECMO or the extracorporeal membrane oxygen. And there the only drug of choice is dexamethasone and dexamethasone plus tocilizumab if they have been admitted to ICU in the last 24 hours. So with this quick summary slide on treatment, I will go on to the mechanism of action very quickly. I think that's very important to understand as we discuss what medications should be used, what medications should not be used. So Remdesivir, as you can see here, it basically inhibits the viral RNA-dependent polymerase enzyme, and it kind of ultimate goal is to prevent the viral replication. Fevipravid is the other antiviral, which was recently approved by the Drug Controller Journal of India, DGCI. it also inhibits the same enzyme and thus limits the viral replication. Then there are other medicines such as tocilizumab. So it binds to the interleukin-6 receptor and it prevents the interleukin receptor activation. And we see as a anti-inflammatory medication trying to limit the collateral damage caused by the IL-6. If you look at the monoclonal antibodies, so the monoclonal antibodies in the market and which have been approved are the imdevimab and casirivimab, the one which I mentioned earlier, have been approved by Roche. So it binds to the receptor binding domain of the spike protein, and it kind of neutralizes it or does not allow anything else for bind to it. So once the site is blocked by these antibodies, it cannot bind to the ACE2 receptor, which is the receptor for pathogenicity and for initiation of infection with SARS-CoV-2. The other monoclonal antibody combination which has been in the market is the bamlanivimab and itesivimab, and it also prevents the viral binding or fusion with the host cell. So, as I said, this is from Hindustan Times, I think from a few days ago, of May 5. So it kind of talks about that it has been approved, and I think as more of it gets available, I think it would be really good for our patients who have diabetes or who are immunocompromised or who are in general at high risk for developing severe COVID-19. We had a huge success in our hospital using these monoclonal antibodies where we could prevent. I actually personally took care of a patient who was 95 years old and he developed COVID-19. And we thought that he had multiple comorbid conditions, including diabetes, high blood pressure, and we got him a monoclonal antibodies, and he did fine and did not develop any complications. So switching gears, so I think in the previous slide we discussed about treatment of mild to moderate and then asymptomatic individuals. This is an excellent slide from ICMR. I think you must be very familiar with the slide. It talks about, if you have symptoms of COVID-19 but no shortness of breath, then these are the things you should do. So monitor your temperature, oxygen saturation, keep the ventilation, isolate yourself. Everyone should wear a mask, and then certainly what treatments you could consider. I want to highlight this that many of our population people, they may not understand English. So I think once we are reaching out to patients, especially in Himachal, in rural areas, if they are not, it's good to have something in local languages like Hindi, where they can easily interpret it and follow those guidelines. So now I'm going to quickly touch base on individual medications which we are using. And then I'm sure people will have questions because we have seen mixed information about Remdesivir in Indian media, where some physicians are saying it's not effective, should not be used. So we can save those questions for the end. But Remdesivir is a IV nucleotide. As I highlighted, it binds to the polymerase enzymes, it inhibits the viral replication. I think the key point I want to highlight is that in a multinational placebo-controlled randomized clinical trial, we found that Remdesivir was effective in severe COVID-19. It did reduce time to clinical recovery. People who were hospitalized and were on supplemental oxygen, which means not on high flow, not on BiPAP, not ventilated, but just supplemental, like nasal cannula, that's where Remdesivir was found to have most apparent benefit. And that did lead to reduced mortality. I think the WHO study, which was done, did not look at the subgroup analysis of this subgroup of patients. And I think they analyzed the data in whole, and where it was found that Remdesivir wasn't effective. But when you do the subgroup analysis, it had a mortality benefit, and it did reduce the time to clinical recovery in patients, specifically on supplemental oxygen. And I think that's why it still is the part of guidelines for management of COVID-19 in the United States. The second medication, which we have seen late reports, is Fevipravid. I think this medication has received an approval from the DGCI for use in India. The only good randomized clinical trial I could find was in Nature, which was published, I would say, about a month or so ago. So this is, again, a RNA-dependent polymerase enzyme inhibitor. The goal is to limit the viral replication. Previously, it was, used for Ebola and flu in Japan. So this was an interesting study. The sample size was 100, but we can see that it led to resolution of the virus shedding by day 14. As you can see in red, about 90% of patients did not have virus in their respiratory secretion by day 14 when compared to hydroxychloroquine. So again, a very preliminary data, we need high-level data, but this is something which was used. The main side effects of Fevipravid noted in this study was hepatotoxicity. Ivermectin, I see that, and Dr. Himanshu, when he's gonna quickly share the ICMR guidelines for management. So I see that ivermectin has been used and is being used in India. So wanted to share this good randomized clinical trial, which is the only study I found. I think the other studies we have are either cross-sectional studies which have high risk for bias. So ivermectin is known to reduce the binding of the virus to the proteins in our body. So they did this randomized clinical trial where they had about 400 patients who got the ivermectin, actually randomized, 200 got the ivermectin and 200 got the placebo. And they looked at the resolution of symptoms within a 3-week follow-up period. And as you can see that ivermectin, the median time to resolution was 10 days, with placebo it was 12 days. But if we look at the confidence interval, it crossed 1, so it was not significant. So at this time, I think there's insufficient data to recommend again, like either for use of it or against the use of it. I think ivermectin otherwise is a harmless drug. It does not have many serious side effects, so it could be used, but I think we need more data to support its use for COVID-19. On a side note, I do want to mention that in India, and I think in many of other countries, we have high rates of strongyloides, which is a parasite that many people have it. And then when these patients develop COVID-19 and when they get steroids, it can lead to hyperstrongyloides syndrome, which can also lead to ARDS. So if you have patients who have a past history of strongyloides infection, they could get prophylactic ivermectin for prevention of the disseminated strongyloides syndrome. The next medication is hydroxychloroquine and azithromycin. I see that it was also part of the ICMR. I think there are multiple studies which clearly highlight that both hydroxychloroquine and azithromycin do not have any beneficial impact for patients with COVID-19. Instead, we have seen serious side effects both with hydroxychloroquine or chloroquine when used in hospitalized patients. So the National Institute of Health panel, they recommend against use of both the hydroxychloroquine or chloroquine and azithromycin. Coming on to inhaled steroids, we have seen some promising data. I think it's the similar mechanism of action as the oral steroids, but the good thing is with inhaled steroids, you do not have systemic side effects. So there is some role of inhaled steroids in early COVID-19 when the virus has not disseminated into the systemic circulation. So there was a good study done in Lancet, published in Lancet, where they looked at about 73 patients randomized to budesonide, 73 to usual care. And as you can see on the right, that people who were in the budesonide arm had a higher rate of clinical recovery. So at 4 weeks, almost like 100% of patients in the budesonide arm recovered compared to 80% in the regular care. So there is some rule of using budesonide inhaled. Again, I think we need to stress that for our patients that it should be used with a spacer device so that we can have maximum amount of medication reach into the our airways and below. Dexamethasone, I will leave it to Dr. Himanshu. He has covered in detail in his presentation, which would be next. Tocilizumab, so again, we have seen mixed data earlier, but lately we had very convincing data from the Remap CAP trial. There are 3 main protocols that I have seen. So it could be used 400 milligrams IV. Some people do 8 mg per kg on day 1, and they repeat it on day 3 if there is no response. And then some people do just 8 milligrams per kilogram to maximum of 800 milligrams, and then they repeat only if there is no response or if symptoms worsen. So this is the a quick comparison of the convincing data that we had from the Remap trial. So as you can see, we had 366 patients to tocilizumab, 412 in the usual care, and then they compared it with sarilumab, 48 people. And then you can look at the in-hospital mortality, which was 28% in the tocilizumab group compared to 36% in the usual care. So it did reduce mortality. And then we also look at the days of invasive ventilation, which were 104 in the tocilizumab and 121 in the usual care group. I think it's important to note that the tocilizumab was only, beneficial and did not lead to worse outcomes if it was given within 24 hours of admission to the ICU, or if it was used quickly around the time when patient was worsening. If patient is already on ventilator for many days, there is no point using tocilizumab. And as I would discuss later, it has more side effects. So going on to the next slide, vitamins. So we see that multivitamins, many vitamins, vitamin C, vitamin D, zinc are being recommended in the ICMR guidelines. So vitamin C is otherwise harmless, but I think if it's used in very high quantities, like IV vitamin C, I actually had a patient who was using IV vitamin C, and it led to crystal formation in his kidneys, and he ultimately required dialysis because his kidneys failed. So I think we need to be very watchful on how we are using them, because a dose is what differentiates a medicine from the poison. So if you use a very high dose, a good medication can become a poison. And I think patients may not understand what a right dose is. So I think it's very important to share with them that they should, use the dosing in the right quantity, or use natural methods like fruits or vegetables which have enough vitamin C that the body needs. For vitamin D, again, there's insufficient data. I do want to highlight that it's a fat-soluble vitamin, and it could be toxic because it would deposit in your body. It can cause liver failure and other symptoms. There is some data highlighting that people who have vitamin D deficiency are more likely to have severe COVID-19. There is some correlation of vitamin D in regulating our immune system. So I think if someone is vitamin D deficient, it is a good practice to replace the vitamin D. And lastly, about zinc, there is the NIH panel recommended against using zinc supplements above the recommended dietary allowance. So again, there's insufficient data for use in COVID-19. So I'm going to quickly switch gears to mucormycosis. I think it's in headlines. I had actually a personal experience treating a patient. This was one of the first patients we found in the United States who had mucormycosis. And we actually reached out to CDC, and we published this interesting case in Journal of Fungi this year. So I had a man who was 53 years old, who basically came up with COVID-19 symptoms initially. He had no symptoms. On day 4, he had to be admitted because he started noticing fatigue and shortness of breath. He was discharged on day 11 with home oxygen. He did receive tocilizumab and methylprednisone and convalescent plasma. And this was taken care of by the critical care team at that time. At day 16, which is about 5 days after he was discharged, he was readmitted. The PCR was still positive, but his chest X-ray showed increasing airspace density in his lungs. It also showed a bilateral pleural effusion. And in next few days, as you can see, that his hypoxia worsened. So he went from 3 liters to 80% FiO2 at 30 liters per minute. And then the sputum culture showed filamentous fungal elements. The CT had shown ground glass infiltrates with a loculated right-sided pleural effusion with a cavitary pneumonia. So until this time, patient was on vancomycin, piptazole, but once we knew that he had a fungal stain positive, he was switched to liposomal amphotericin B, and subsequent workup revealed that it was Rhizopus species. He ultimately underwent video-assisted thoracoscopic decortication of the right lung. But even with everything that we did, he ultimately developed respiratory failure and shock, and he died of cardiac arrest on day 33. So again, highlights high mortality in such patients. As this case highlights that he has COVID-19 in the past, he recovered, and then he got worse. And I think that's what we are seeing in India as well. So it's caused by the subphylum Mucormycotina, order Mucorales. The risk factors are immunocompromised patients, which are malignancies, transplants, but also patients with diabetes, iron overload states, patients who are injection drug users, and who have penetrating trauma. So major sites of infection are sinuses, lungs, skin, brain, and GI tract. I think sinuses are very common because they are very close proximity to the environment where this fungus is. It's typically found in organic matter, which is like a plants or dead plants and soil, and people inhale it, or from their hands, it can easily get access to their nasal passage, and from there it can invade into the sinus cavity and to the orbit. We all know about Rhino orbital mucormycosis in diabetic ketoacidosis, but I think with COVID-19 we have seen it also involves other parts of the body. I think there are about 4,269 cases so far. In what we also think that in addition to diabetes and other comorbid conditions prevalent in India, I think COVID-19 itself is a risk factor for invasive fungal infection. We have seen that COVID-19 causes lymphopenia. It attracts lymphocytes from all over the body to come into the respiratory tract, and the lymphocytes die there. And lymphocytes are our major line of defense against fungal infection. So lymphopenia in COVID-19 also predisposes patients to mucormycosis. I think there needs to be a good study in India where we could do some infection control, case control studies, looking at role of humidifiers and hospital water supply, because we did not see a COVID-19 mucormycosis outbreak in the US and other countries. So maybe I think the fungus causing mucormycosis is more endemic in India, but I think we also need to look at the infection control aspect of it, because if we are seeing hospital to hospital transmission, then I think this is one low-hanging fruit which we can do to prevent more cases. I think it's good to have very high degree of suspicion, because the later the patient is diagnosed, the higher the mortality. The drugs of choice are amphotericin B, which is IV, posaconazole and isobuconazole are the oral options which can be used. And I haven't seen any prophylactic data where these antifungals are used prophylactically, because these antifungals also have serious side effects. So I think we need to be very careful. I do want to highlight voriconazole, which is an antifungal, which is also known to predispose or leads to increased susceptibility to mucormycosis. So lastly, I'm gonna come to prevention. It's always better than cure. And I would also say it is much cheaper and more cost effective than cure. So I think we need to understand the COVID-19 chain of infection. So it has mainly 6 steps. So we have a susceptible host and we have the virus. So how can we prevent the virus from getting to the susceptible host, and that's through vaccination, stay home, physical distancing, wearing a mask, and then washing hands. Now, how can we prevent this virus to enter into humans where it can actually cause an infection? That is by washing hands, disinfecting surfaces in the hospital. As healthcare workers, we also need to have a good technique for wearing, like donning and doffing the personal protective equipment. So our masks, our gloves, our gown, we need to be good at how to put them on and then how to take them off. So that's another chain, a link in this chain of infection. How to prevent this virus from getting into our system, which is the portal of entry and portal of exit. So avoid high-risk situation like indoor gatherings or outdoor gatherings where people are congregated together. And then how to prevent transmission to the surfaces around is to like wear a mask, cover your sneeze, stay home if you are sick. And then lastly is to prevent it from getting into our mouth, nose and eyes and wearing a mask. So this is a good slide from CDC, which describes the PPE used. I'm not sure in what's the supply in IGMC and other hospitals in Himachal. In the US, we had a designated people who were maintaining a record of, we have this number of gowns today, this number of N95s, and that information was used in was shared with doctors and nurses so that they could judiciously use personal protective equipment, especially when there is a surge of patients with coronavirus. So face masks, again, these are the ways. This is the right way. I'm sure you all are familiar with this. The only thing I would stress on is hand hygiene when you take the mask off, because if there is a virus on the outer surface of the mask, it can get to your hands. From the hands, it can get to the nose or your mucous membranes and enter inside. So hand hygiene is critical before and after removing a mask. This is for the N95. As you can see, the right way of wearing an N95 mask, not crisscrossing. People who have facial hair, it may not be as effective because it does not create a good seal around the face, and it can allow the virus to enter. And then again, very important role of hand hygiene and properly taking the mask off and discarding it in a designated waste container. There is good role of double masking that we have seen from CDC. So if a patient or a healthcare worker, if we wear a surgical mask and on top of that we wear a cloth mask, I think we have seen that it leads to 95% reduction in exposure to the virus compared to a regular mask or no mask at all. So I think that is something we could easily do. I'm sure that the N95 availability might be a resource constraint in India. So I think double masking could be handy or very cost-effective way of preventing exposure to viruses. Again, I think the people who are high-risk contacts for patients who are positive, it's very important to share this information with them so that they can also prevent acquisition of SARS coronavirus 2. So ultimately coming to vaccines, so we have seen multiple vaccines. The main vaccines in India available are Covaxin and Covishield. I think the Pfizer vaccine is going to be available soon. And then there are the Sputnik V, which is the viral vector vaccine, is going to be available soon. Just vaccines by number. So we have only vaccinated about 14 million of our population. It's good to see that 96%, 66 lakh healthcare workers have been vaccinated. So I think that's a really a good number. I hope more doctors and our nurses, they get vaccinated, because we need to protect our essential workers because they are the backbone of providing care to COVID-19 patients. So I think there was a question, and also people had asked about, can you mix and match vaccine? So I think there was one study that just came out on 19th May, like 3 days ago, from Spain, where they did this trial where they had people take Oxford AstraZeneca vaccine, same as Covishield, and then they gave the second dose with the Pfizer vaccine 8 weeks for 2/3 of the participants, which is about 400 people, and then 232 did not receive a booster. They found that people who had Pfizer vaccine following the Oxford vaccine, which was given initially, the antibody response was much, much higher. So I think this is a promising data. We need similar data with Covaxin, Covishield, and Sputnik V. I think there is one trial going on right now where they're looking at the Covishield and Sputnik V. So I think that would be interesting to see. But I think that would solve much of the vaccine problems. Like a patient got, say, Covishield, can he get a Pfizer vaccine after that or not? I think it would lead to higher rates of COVID-19 vaccination. There was also a concern, a question about vaccination and thrombosis. So I think it is an entity that we know that exists. So we have an entity called VIT. It's called vaccine-induced immune thrombotic thrombocytopenia. It is similar to HIT that we see with heparin. It has been mainly reported with the AstraZeneca or the Covishield vaccine, mainly in women less than 50 years. But I think the incidence is very, very low. It's like 1 case per 100,000. The only way to diagnose is through this antibody, which is the platelet factor 4 polyanion antibodies. There is no specific treatment. There is some role of human immunoglobulin, which could again bind to these autoantibodies, which lead to thrombocytopenia and thrombosis. I think there's a lot of skepticism in public and doctors, and fears also that what if they develop this side effect as a result of vaccine. So I think we should put everything in perspective. So here's this slide which talks about that for a 25-year-old, the risk for serious harm from vaccine side effect is 11 in a million, but the risk from dying due to coronavirus is 23 in a million. And if we say, what's the risk for dying in an accident? It's 110 in a million. And then for 55-year-old, it's very important that he gets the vaccine because the risk for serious side effect is 4 in a million, but his risk of dying from coronavirus is 800 in a million. So you can see these numbers in perspective. So I think when we reach out to patients or family members, we need to tell them that the risk from coronavirus dying is much, much higher than these rare side effects. I want to stress about hand hygiene. It seems very simple, but I think it's very effective. 3 things I want to highlight is that we should use soap and water when visibly soiled. Otherwise, we could use alcohol-based hand rub and any concentration which is more than 60 but less than 95%. We should wash our hands or use alcohol hand rub for a minimum of 20 seconds, covering all areas, including the web spaces. It's good to have no artificial nails use policy among healthcare workers, and we should minimize wearing hand jewelry because those are the areas which cannot be sanitized well, and they could still harbor the virus and it could be transmitted. So, and lastly, I think we need to protect our doctors. So how doctors can protect? They can use double masking, make sure they use the correct PPE technique and material when examining patients, vaccinate themselves, hand hygiene. I think we have seen a huge mental toll on doctors from the suffering, from the death, and from personal losses that they have suffered during this pandemic. So I think it's very important for them to focus on mental health. So yoga, meditation, getting out into the nature. I think those are important things they could do. One thing which we did at our hospital was every doctor, every nurse, before coming to the hospital was screened using a symptom-based questionnaire, and their temperatures was taken. I'm sure a similar thing is going on, but that is a very easier way, as we call it, syndromic surveillance for picking up patients who may have COVID-19, and they can be tested very quickly through a rapid antigen test and then triage into whatever their category is. It's important to focus on sleep, nutrition, eat fruits and vegetables which have good antioxidants. And again, I think one thing which is forgotten in this pandemic is the pandemic which we have seen from diabetes, hypertension, and obesity, and metabolic syndrome, which are, I would say, the main reasons for higher mortality that we are seeing in individuals. I think there is higher mortality in younger people also, but I think that may be blamed on either undiagnosed risk factors or the virulent circulating virus strain. Lastly, I want to bring this up, and I think this is something which we have to discuss in detail in future, that I would be very interested. Dr. Bhardwaj has expressed his interest also in being available for starting something which could offer telemedicine for Himachalis. So we could have a group of doctors in the US or maybe England or elsewhere where we could have a WhatsApp group where a doctor-to-doctor telemedicine consultation can happen. We could set some rules for sharing cases in given format and follow up. So I will summarize again with the same slide, and then I will pass it on to Dr. Bhardwaj for the next presentation, and we can save whatever time is left for Q&A in the end. Thank you.
Can everyone hear me?
Yes, I want to say thanks to Dr. Anubhav Kanwar, and I welcome you, sir, for this session. You're Dr. Himanshu Bhardwaj, MD, and you're going to take the lecture on COVID-19 respiratory failure, pulse for management in the resource constrained times. Thank you, sir.
Correct.
Please
All
take
right.
over the mic, please.
Thank you. Thank you, Dr. Kaur. I want to first thank Dr. Kaur, Dr. Sarkar, and State Institute of Health for coordinating this talk with me and Dr. Kanwar. It's an honor. I graduated from IGMC from 2001 batch. I graduated in 2008, and after that, I did my residency in internal medicine, followed by a fellowship in pulmonary critical care medicine. And now I'm faculty here in University of Oklahoma Health Sciences Center. I'm an associate professor, and we have a large program. And during the surge of pandemic, our ICUs were full just 3-4 months with COVID patients. We had to open up makeshift ICUs, and I can really feel what's going on in India right now. And hopefully it's only gets better with time, the way we are at the tail end of pandemic. But the purpose of my talk mainly is to focus on the practical aspect. What we dealt with. It's a lot of the things we did may not be applicable because of the different resource constraints between America and India. But I think a lot of the practical suggestion will still stay true. The objective is mainly I want to create a platform where we can have a candid discussion and open question Q&A to this talk. I want to share my experiences, our experiences during our pandemic time, early part of this year and most of the last year, what we dealt with. And last but not the least, we want to create a channel for consultation for via telemedicine for all our physician colleagues in Himachal Pradesh. I think this is the least we can do. We really want to help, and I think from experiences, what we learned, it definitely can help each other from this. So as we know, this slide just talks about how overall the clinical symptoms and progression of COVID disease happens. Dr. Kanwar talked about in much more detail, but usually there are three phases. You have early infection and in initial 5-6 days, and after that there's a pulmonary phase and hyperinflammation phase where patients do get sick towards the second and the third stage with ARDS. Nobody knows why 10 to 20% of patients go into these stage 2 and stage 3, because most of the patients do well. So we don't know why some people get sick, but they do, and the numbers are staggering in India right now. So this is very important to look at. We have all seen these kind of X-rays. You can see patchy consolidations, small pleural effusion, not big pleural effusion, perihial distributions of these consolidative, peripheral distributions of these consolidative changes. And then on the CAT scans, we have seen these dreaded CAT scans where you see these ground glass opacities, you see these patients going into florid ARDS. But that being said, do we really need all these chest X-rays, CAT scans, especially in a resource constrained times where you don't have the access to CAT scans? And this was a big problem for us with 2 CAT scan machines in one of our hospital. We were still having a hard time, and I can only imagine how difficult it will be. So American College of Radiology actually have some guidelines about it. Do we really need CAT scan? Probably not. The main reason why ACR recommended against using as the CAT scans or even chest X-rays was, first of all, the COVID-19 diagnosis is based on the RT-PCR. You cannot accurately distinguish just based on the CAT scan or chest X-ray. So, and then with other viral disease, seasonal flu, and sometimes even your Rhino virus infections, you can see these patchy opacities. So that's probably the reason ACR was not very supportive of doing CAT scans. And a lot of the COVID-19 patients don't have any abnormal changes on the CAT scan. So in my opinion, unless it's needed, and we'll talk about why you would need CAT scans or chest X-rays, probably CAT scan more important, more resource consuming imaging studies. So few of the situations where we do consider doing CAT scans, and these guidelines do come from Fleshner Society, the society that usually deals with the recommendation on the lung cancer screening CAT scans. So they mentioned in their official guidelines that if you have a patient you highly suspect COVID-19, for whatever reason your RT-PCR results are not coming out positive, whether the poor technique of doing RT-PCR, you can consider doing a CAT scan in those patients. In patients where you are considering alternative diagnosis for patients, for example, if you have a patient with COVID-19 and you are suspecting a pulmonary embolism, then you want to do a CTPA, and that would also help you to look at the parenchyma. If you're suspecting small pneumothorax not visible on chest X-rays, if you're suspecting secondary bacterial pneumonia, then again, in those situations, you can. One of the most common reason why we are doing CAT scans now for these patients who have recovered, and not exactly for acute COVID situations, but patients who have recovered and we are suspecting fibrotic progressive lung disease, we are getting high resolution CAT scan on them. But besides these situations, I think especially to save our resources and to prevent contamination from moving patients to CAT scan machines and dealing with all the cleaning and avoiding infections in healthcare workers, I really don't think we should CAT scan every patient. And this was, I think, also talked about by AIMS director a few weeks back, that CAT scanners are being overused in India, and I would probably suggest to be very cognizant about ordering these CAT scans. So now, this was just about the imaging. Now, talking about, these are the official guidelines from AIMS, ICMR, and Dr. Kanwar already talked about the NIH guidelines in America. So mild, moderate, severe disease, and there are different guidelines. it's a moving target. It's not very hard and fast rule. What is mild? What is moderate? What is severe? NIH also has a critical care, the critical disease category, the fourth category. But this has already been talked about by Dr. Kanwar, the guidelines in NIH. But talking about the Indian guidelines, for mild disease where patients are not sick, they are just dealing with mild cough, the simple home-based care is okay, using anti-fever medications, your paracetamol in India, ibuprofen, and just keeping an eye on patients who are at high risk. So patients like over 60, patients who have cardiovascular disease, those are the patients who are at high risk. And as we talked about in the previous talk, the monoclonal antibodies should be considered if they are available for these high-risk patients. ICMR do talk about ivermectin, hydroxychloroquine, and inhaled steroids, as I mentioned here in may-do category. The evidence is not very strong with these, and as Dr. Kanwar mentioned, I would suggest against using any of the medications which do not have an evidence. We are in a slippery slope in that area. Our first duty as physician is not to cause any harm, and with this uncharted territory, we dealt with this with the hydroxychloroquine. I'm sure we ended up causing much more cardiac side effects. So in my personal opinion, we should avoid these medications which do not have any strong evidence behind them. For moderate disease, as Dr. Kanwar talked about, these patients should be admitted. They should be given oxygen therapy, which we'll talk about a little bit more detail. Steroids should be a consideration. I'll go a little bit more detail. These patients should get antithrombotic or thromboprophylaxis for DVTs. COVID patients are known to have hypercoagulable states, so higher risk of DVTs or even the arterial blood clots. So that's something to which we'll discuss in a little bit more details, and keeping an eye on these patients in terms of how their oxygenation is doing, and making sure if they go into severe disease, deal with them, take care of them in the ICU, moving these patients to ICU to more advanced oxygen therapy, high flow nasal cannula, non-invasive ventilation or intubations, and all these things I'll talk a little bit in more detail in specific slides dedicated to these. And these are the off-label still emergency use authorized drug, and these are similar in the United States and India right now. Remdesivir, Dr. Kanwar talked about the detailed criteria, tocilizumab. Convalescent plasma, even ICMR has taken it out. We stopped using plasma long time back. It's still recommended if in context of any clinical trial, but I would suggest against using plasma in most of the situations. So ICMR also recommend against. So this was the old recommendation. Talking about the steroid therapy in a little bit more detail. Only the patients who are on supplemental oxygen or ventilator support should receive steroids. So patients who are not requiring any oxygen, they should not receive steroid therapy. Choice of agent, dexamethasone was the agent that was studied in the trial, the recovery trial, at the dose of 6 milligram for 10 days or until discharge, whatever happens first. So you don't have to always use 10 days. If patients get better in 5 days and they get discharged, you can stop in 5 days. There should not be any reason to use higher dose than 6 milligram, which was the recovery trial dose. And I think part of the reason why we are seeing so much of mucormycosis in India right now is the more than recommended doses of steroids are being used, and that's causing this excessive hyperglycemic state, causing the mucormycosis. So stick to the guidelines, use the recommended dosage, and If dexamethasone is not available, it is reasonable to use equivalent doses other steroids. For example, you can use hydrocortisone 150 milligram daily, methylprednisolone 32, or prednisone 40 milligram. But keep in mind, these other agents, the data supporting the other agent is not as robust as dexamethasone. So I would suggest try to stick to the trial criteria, use dexamethasone at 6 milligram doses, no more than that. Now, moving on to the oxygen therapy. As we know, there are different forms we can give oxygen. Simply, you can use nasal cannulas. You can advance to non-rebreather. Patients who are more sick, we have the options of using high flow nasal cannulas or non-invasive ventilation. And patients who are critically sick and not able to maintain oxygenation with all the available options, then intubation and mechanical ventilation is the last resort. The optimal oxygenation, we don't know exactly, but from the other trials which looked at this, the optimal oxygen target in ICU, probably low and high target both are bad. So sticking somewhere between 92 to 96% of oxygen saturation, anything below 92 can be harmful, and anything above 96 probably is harmful, over oxygenation from oxidative state. So that's usually what we use here, between 92 to 96%. And for each modalities of oxygenation, for nasal cannulas, usually we start in the inpatient settings around 5-6 liter per minute, and maximum FiO2 we can achieve, as we know, with the nasal cannulas is around 45%, because of the mixing that happens from room air while patients are taking breaths. Keep in mind on the nebulization of the dispersion of the exhale air, which can cause dispersion of the virus throughout the room and even in the whole ICU. So we try to put a face mask even without oxygen whenever we use the nasal cannulas, so that the dispersion of the respiratory particle is minimum and at least somewhat covered from the face mask usage on top of the nasal cannula. Venturi masks, they are more studied in your COPD patient where you want very specific FiO2, but they do give you higher flow, so higher than the nasal cannulas. You can go up to 2 to 15 liters. But if you come to that point, we rather use the non-rebreather mask, which you can achieve much higher FiO2, and the flow rate can be brought up to 15 liters. So that's an option. As patients oxygenation keep getting worse, if they're not getting better, the high flow nasal cannulas, they are actually very useful in this setting. The way they work, because of the very high flow, the anatomic dead space is reduced. The work of breathing gets better in these patients, and they also provide a little bit of positive airway pressure, PEEP of around 3 to 5, with the highest flow, high flow nasal cannula at 60 liter. So, and this has been studied to show mortality as benefit, as well as improvement in intubation rates in COVID patient, as well as in any ICU patient with hypoxic respiratory failure. And they are even preferred over the non-invasive ventilation. For the non-invasive ventilation, CPAP and BiPAP usually are two options we use. One of the worry with the BiPAP devices is the dispersion of the aerosolization of secretions and the aerosolization of the virus particles and increased risk of infection. So that's probably that's the reason Society of Critical Care Medicine here, we recommend against using non-invasive ventilations, and unless, so if you have an option of using high flow versus non-invasive, SCCM recommends using high flow over the non-invasive positive pressure ventilation because of this risk. and the ultimate oxygenation, the intubation. If the patients are not getting better with all these interventions, then the last option is intubate the patient and put them on mechanical ventilation. And we'll talk a little bit more detail with everything. So as I talked about, high flow nasal cannula versus non-invasive positive pressure ventilation, uh, when you have an option, high flow nasal cannula should be preferred. And this is also the NIH guidelines here. And it has clearly shown that high flow nasal cannulas provide more ventilator free day, less 90-day mortality, and less intubation need in ICU in hypoxemic respiratory failure. Even though this was a non-COVID RCT, but this probably still stands true for COVID patients too. Awake proning. This has been talked about a lot. A lot of people have talked about in social media awake proning. How does it work? When we lay on our back, when we are supine, there is a certain degree of atelectasis which causes a VQ mismatch, and that gets even more exacerbated in patients with underlying ARDS. So what proning does is it opens up these atelectacy area, improves the VQ mismatch, and also helps in with secretion clearance. And eventually, all this does result in some oxygenation improvement. So NIH and both ICMR guidelines do suggest, if patients are able to tolerate, use awake proning if possible. As much as the mortality benefit is very established in intubated patient, usually it's the benefit in awake patient is not, in terms of the mortality and morbidity, is not very clear. That being said, when we used awake proning in our population, we did see improvement in oxygenation, and it does not harm. So I think if, as long as we don't expect wonders from this intervention, as that happens in intubated patient, I think there is no harm in recommending awake proning. But I would probably keep the expectations not very high with patients, that it's not something that's going to cause mortality improvement. So this flow diagram here talks about how to deal with the patients with the hypoxemic respiratory failure, stepwise basis. So anytime we have patients we are seeing first time, always look at if there's a need for endotracheal intubation. If patients are able to tolerate regular supplemental oxygen, able to maintain their oxygenation, then consider high flow nasal cannula or simple oxygenation to begin with. And if patients are not able to tolerate high flow nasal cannula, always keep an eye, is my patient getting sick to the point that they need intubation? Never delay intubation just for the sake of using these other interventions. So for that reason, these patients need very constant evaluations every 2-3 hours, making sure they are tolerating the oxygenation what we are doing, and they are not heading towards intubation. If one of the questions that was sent to us from Dr. Sarkar was, is there any specific indications you can stick to, any specific timings for intubation? In ICU, what we say, if you feel like you have to intubate the patient, you probably should intubate the patient. That probably stands true in for physicians who are very experienced in dealing with hypoxemic respiratory failure in ICUs. But for physicians or for doctors who are doing it on not a regular basis, probably some of the criteria is what we look at sometime. If there's a rapid progression of hypoxia over few hours, that's probably you should consider putting these patients on mechanical ventilation. If there is lack of improvement in hypoxia with almost highest high flow oxygen, more than 60 liter, FiO2 at more than 60%, that's probably the time you should start considering intubating these patients. If patients start developing hypercapnia on whatever interventions you are using, high flow or non-invasive ventilation, their workup breathing is increasing, and you see decreased tidal volume on the non-invasive ventilator machine, then it's probably patient is getting tired out, and it's better to consider intubation. And of course, the mental status, if that's getting worse, that's probably another reason you should consider early intubation. Patients who are getting hemodynamically unstable, frequently these COVID patients have septic shock from COVID itself, and sometimes from bacterial superimposed infections. In those patients who are running into hemodynamic instability, if we are seeing multi-organ failure, like kidney dysfunctions, neurological mental status changes, probably you should consider intubation. And one of the thing about the intubation, in specifically in COVID patients, it's one of the highest risk procedure in terms of the infection potential to the healthcare providers. And it's much better to plan for intubation and mechanical ventilation in a planned way than emergent way, because the risk of something a break of barrier of PPE is much more in emergent intubation than in a very planned intubation, where you can take time to make sure everybody is gowned up, everybody is in recommended PPE. So in the early days of pandemic, there was actually a big push about intubating these patients, even more than considering them on high flow nasal cannula or non-invasive ventilation. But over the time, that practice has changed, and but we still consider intubating these patients in a much more planned fashion than in emergent way, just to make sure we don't end up infecting our healthcare providers because while doing the procedure. Some of the basics about the mechanical ventilation. I know not everybody here deals with mechanical ventilation for physician where it applies. What we have figured out, or what we have seen over the last few months, that most of the time these patients who need mechanical ventilations, they behave like a usual ARDS patients. In the beginning, especially from Gattinoni, who is a big name in ARDS in Italy, there was a push about a different form of ARDS, low compliance, high compliance ARDS. But I think we should stick to the basics, use the ARDS low tidal volume protocol, probably use higher P protocol, which is here at the bottom. Low PEEP versus high PEEP. These tables are from ARDS network recommendations, and keep the oxygenation goal between 90 to 92%. If you are checking your blood gases, keep a target about more than 60, but stick to the basics. Don't try to do something which you haven't done before. Is any mode better? That was another question that was sent by Dr. Sarkar. Probably not. In the end, it's not the ventilator, it's the physician behind the ventilator who saves the patient. So that being said, I don't think there's any mode better than any other mode. The most conventional mode which were used in ARDS network trial were assist control, volume cycle at target tidal volume of 6 ml per kg, keeping an eye on plateau pressure less than 30. This is the most common mode we use, and this should, in my opinion, this should be the practice, standard practice all throughout. And if patients who are not able to maintain oxygenation despite doing the proning, despite doing all the interventions which are available in your hospital, then there is some data that these specialized mode of ventilation, for example, airway pressure release, APRV, or recruitment maneuver, and much higher PEEPs, that may help. But in my opinion, the best mode is ACVC, and stick to the basics and don't try to do something which has not been studied well. Analgesia and sedation. This has been an issue, and what I've spoken to several physicians. I think the biggest thing in ICUs is to avoid benzodiazepine drips. The midazolam drip is very common, and it's very commonly abused. and try to use more analgesic agents, fentanyl and morphine. Propofol, if patient is hemodynamically stable, that's our first choice. Propofol drips, continuous drip, as long as you keep an eye on lipid panel, because it does cause some hypertriglyceridemia. But that's probably the most important things, just avoiding the benzodiazepine drips. Proning, as opposed to the awake proning, it's life-saving in your intubated patients with ARDS. It has over time and time again, this has shown to be mortality benefit. I think number needed to treat is around 9 or 10. So every 9 patient you will prone for ARDS patient, you will save 1 life. So this is probably underutilized and easiest intervention we can do. It doesn't need any specific instruments. So I would advise to consider proning much more than what I have at least noticed in Indian population. Typically within 12 to 24 hours, that was the trial from France. How within 12 to 24 hours of ICU admission, patients were prone. Most commonly, it's used in severe ARDS patient, but I don't think it causes any harm if we start considering even early proning in COVID-19 patients. So based on the PaO2 FiO2 ratio, but this would be an easiest intervention we can apply, and this will definitely save lives. I think this is very underutilized, even in United States, and I think in India too. So this would be one of the things I would really strongly suggest, that for ICU patients, this will save lives. A brief slide about neuromuscular blockade. The mortality benefit is not there. The most recent trial did not show any mortality benefit of neuromuscular blockade in intubated mechanically ventilated patient. That being said, this does help in a small group of patients who are in severe ARDS. It does help to improve patient synchrony. So patients who are very hypoxic despite the most maximum ventilatory support, we do use neuromuscular blockade. Most commonly, at least in our hospital, we use continuous cisatracurium drips, Nimbex drip we call. But depending on what we have in whatever hospital we are in, it's okay to use intermittent boluses. And it does decrease the respiratory muscle O2 consumption. And I think overall it helps, but the mortality benefit is not there. You will have much more better control over patient and the ventilator in a neuromuscular blockade patient. So I don't have any opposition about using them in severe ARDS patient, but it does not improve the mortality. For rescue strategies, there is a role of our inhaled vasodilators. They may not be available in most of the hospitals. Even in our hospital, it's case-by-case basis. We rarely use them. But if you have an option and availability of specifically the epoprostenol, we do use them as a rescue agents for severely hypoxic patient. But again, there is no mortality benefit. Probably you will achieve some improvement in hypoxia for a few hours, but there is a role in severely hypoxic patients. Talking about antithrombotic therapy in COVID patients, there are different school of thoughts, but the most I could get combination of the NIH guidelines and the guidelines from the AHA, American Heart Association. All the hospitalized patients should receive prophylactic doses. There is no reason to give more than the prophylactic doses of anticoagulation. Preferred agent is low molecular weight heparin, 0.5 milligram per kg, around 40 milligram. That's what we use. Patients who are rapidly deteriorating because of the pulmonary, cardiac, or any neurological functions, because of the high risk of thrombosis in COVID patients, there is a low grade recommendation that it's okay to consider thrombolytics or full dose of anticoagulation in those patients. But I don't see any reason why to give more than the prophylactic dose on these patients. And this table here does show that if you have patients who are being hospitalized and the preferred agent is low molecular weight heparin, and in patients who have renal failure, for whatever reason they cannot use low molecular weight heparin, unfractionated heparin and even fondaparinux can be an option. Now for outpatient, the data is not very clear. Most of the outpatient COVID patients should not receive antithrombotic therapy, except in situations where you have high risk for venous thromboembolism, and those high risk, those are very specific in guidelines. Patients who have had prior history of venous thromboembolism, patients who have had recent surgery, specifically the joint surgeries or limb surgeries, or prolonged immobilization, or if they have obesity with BMI of more than 40. Except these situations, there is no reason to give antithrombotic therapy in outpatient settings. And that also applies after the hospital discharge. So after patient gets discharged, there is no reason to give, no guidelines support giving the post-discharge thromboprophylactic therapy in patients. Those high-risk groups we talked about, there is we can consider giving thromboprophylaxis, and in those situations, instead of giving the injections of heparin, the oral agents should be preferred. And our most preferred agent in our population here is apixaban, but rivaroxaban is an option at lower doses. And the duration usually we use is around 30 to 40 days post-discharge. But except these high-risk situations, I don't see any reason why these patients should receive thromboprophylaxis. That again, I mean, we are dealing probably causing much high risk of bleeding at no additional benefit of preventing venous thromboembolism. So that's something I wanted to highlight. This flow diagram here just shows how the escalation of cares from simple hospitalization to ICU, depending on how patients progress. And the bottom bullets here talk about the overall approach, which I have already talked in detail in previous slides. The conservative oxygen therapy, keeping a low tidal volume, using higher PEEP, neuromuscular blockade, and for patients who eventually get better, extubate and discontinuation of the mechanical ventilation. And the ultimate goal is discharge home after that. Dr. Sarkar also sent us a query about post-COVID fibrotic lung disease. Since we are at tail end of pandemic here in the United States, we are seeing these patients now who have recovered from COVID ARDS, and we are seeing these patients developing interstitial lung disease. Most common pattern, what we are seeing, and we actually have a post-COVID ARDS clinic in our pulmonary section here, where we specifically see these patients. What we have been seeing is the pattern is organizing pneumonia. Not everybody is developing that, but around 5% of the population. So we are seeing these peripheral consolidative changes in organizing pneumonia pattern. Treatment-wise, the only good data is this article from Mail Mukherjee and all it was, I think, just published a couple of weeks back in Annals of Thoracic Medicine. So in this retrospective, or more like an observational study, they gave steroids to these patients, and 0.5 milligram per kg. So for an 80 kg patient, around 20 milligram daily for 4 to 6 weeks. And the improvement was pretty dramatic in these patients. So here's the figure from this trial. On the upper hand, you can see these post-COVID organizing pneumonia pattern, and after 4 to 6 weeks of steroid therapy, at the bottom C and D, we can see how the X-rays and the CAT scans have improved so much. So that's what I think my recommendation would be. If these patients are complaining of dyspnea at 6 weeks after discharge, do a CAT scan. If you see an organizing pneumonia pattern, consider doing steroid therapy at 0.5 milligram per kg for 4 to 6 weeks. Antifibrotic agents which have been approved for IPF and progressive ILDs, two of agents, pirfenidone and nintedanib. There is no role, at least at this point. There are some trials going on to use these agents, but I would suggest against using these agents unless they are being used in context of clinical trials. So we are not using these agents. The only thing we are using is the oral steroids for 4 to 6 weeks in these patients. So this is mostly about the management part. Last small section of the talk, I want to dedicate to what's going on in India and what we should try to. It's just recommendation. Some of these intervention we use during our pandemic, and I know the resources are much availability is much different in India versus what we had, and even with so much resource availability, we were put to our knees with big surge and the number of patients. But one thing to consider when we are looking at the resources is most of these patients do well. Only if you look at the left side of this diagram, 80% of the patients will do well, and only 20% of the patients will require the healthcare setup. And the top 5% patients who will get really sick and require the critical care in the ICUs, they will use the most of the resources available in the healthcare. So focusing on these top 5% patients in terms of the resource utilization and try to see what we can do the best for these top probably will help all the bottom one in terms of the resource utilization. So that's why we should focus on the most critical ones to keep an eye on the resources. Some of the intervention specifically for low resource settings, and we were dealing with that too. So awake proning, as we talked about, dealing with airway secretion management just with simple chest physical therapy will help with hypoxia in these patients, and probably you can avoid in a fair amount of patients intubation and use of mechanical ventilation. Avoid using unnecessary antibiotics. Only 10% of these patients have bacterial infection, and that actually develops towards the later part of their hospitalization. So it does not make sense to put all these patients on antibiotic right from the beginning. Even throughout the course, only 10% of patients will develop any bacterial infection. So keeping an eye on that. Otherwise, with all the shortage we are seeing, eventually there will be a time where you will start seeing shortage of antibiotics with so many cases in India, and then all the patients who will really need antibiotics, they will be the one who will not get the antibiotics, and it's just a conundrum. So just on all the small things which we can do, which we can help save in low resource settings, will go in a long way in terms of the overall care of the community, overall care of all these patients. Frontline workers, all low resource settings, even with us and specifically in India, I don't think we have enough ICU trained physician. I don't think we have enough hospital trained physician to take care of them. So taking care of the frontline workers should be the utmost and the most priority in these settings, because if one healthcare worker or one physician falls sick, that's probably in the end going to end up causing deaths of probably hundreds of COVID patients, which could have been saved by that physician. So this should be very, very important to make sure the availability of PPEs is very important. The mental health, the overall health well-being of the healthcare worker is being taken care of. This was very importantly addressed from the very beginning in the United States. We were as healthcare workers, we were appreciated very well. And I think that should be the thing in India, and healthcare workers are underappreciated there. So this is very, very important. I want you to highlight that the well-being of the healthcare worker eventually accumulate to the well-being and even saving lives. So that should be the very much focus of the authorities, of the government, of the hospital, of the community in general. So it should be very, very important. I cannot emphasize it more than enough. And when you have scarcity of the resources, probably designating less specialized work to other healthcare worker should be focused. So, for example, if some uh, if some physician is trained in ICU, they should just be supervising the ICU role, and the other roles, for example, dealing with the families, talking to the families, dealing with the blood draws, placing catheters, they should be designated to other specialists. This was one of the action plan. We had several one in our heights. This is from University of Healthcare, Oklahoma Healthcare. What we did, we made several teams from different physicians who were not this is specifically for ICU, not for the hospital, but for ICU. And this probably the same model should apply to hospital too. So what we did, we created teams, several teams headed by an ICU physicians. And in India setting, it can be an anesthesia physicians. In United States setting, these were pulmonary and critical care physicians. And with that, we created 6 or 7 teams with non-ICU physicians, sometimes even non-medicine physicians, surgeons, thoracic surgeons, trauma surgeons. And the role of the ICU physician was to supervise these other physicians. So there was the ICU physician will start round in the morning, and they will go to each team throughout the day. And if there's any emergency that can only be handled by the ICU physician, they will go back throughout the day. So that ways you get an expertise of the physician trained in ICU to several more than what you would expect if you are specifically responsible for the patient. So in that way, one physician can see 50 or 100 patients in terms of the supervising. So I would suggest, if there's an option similar to this, doesn't have to be exactly like these models should be endorsed depending on the institute to institute. The last couple of slides, if this is one article I suggest everyone should read. This was published in 2020 in the height of a pandemic in New England Journal. The toughest triad, how you should consider allocating the critical care sources. This was more specific to ventilator, but probably applies to every resource, every life-saving resource in pandemic time. What this article talked about, that if the cases are so much, patients are dying, and you are not able to save, you probably should start rationing the care and start focusing on patients who you will save the most number of years lived. So young patients, and basically trying to save the patient who will live the longest after the triage. So what this article suggested, and we actually may use kind of this format, and I would suggest that this should be a similar way. If the caseload becomes unbearable and we are not able to, it's better to save, we can save, rather than to not save anyone. So that was the gist of this article. The bottom line was, consider creating a committee which is not the physicians taking care of the patient should not be the part of the committee. The politician for sure should not be the part of the committee. This should be a committee governed by different specialists. There should be probably a religious leader in that committee, and create a decision-making capacity where you can make decisions. Hopefully nobody goes to that extent, but the way the number of cases, this should be something, at least have a planning ways. It should be in the back of our mind that the patients who are too sick to be critically care, and who's going to eventually end up causing the wastage of resources, not going to be living even after providing the critical, probably consider letting them go based on the committee recommendations. And patients who we really can save, who are young and who really can live long life after being saved, they should be the highest priority. But again, we never reached to this point. I hope nobody ever reached to this point where we have to ration the care. But looking at the extent of oxygen deterioration and the availability of oxygen all throughout the India, which I hope is better now, but that should be a consideration, at least from the leadership perspective, that it may come to that point in heights of pandemic. Last slide of the talk. I do want to talk about the misinformation and overload of information in this day and age. I know it's very easy to get consumed by media. Media has an invested role in making profit from viewership and clicks. They often will sensationalize the information, and some of the information is simply false. And for our physicians, healthcare providers, it can be very frustrating. I've seen so many videos on Facebook by healthcare providers in India, how frustrated they are. And this is definitely a big concern. Some of the coping skills, these were recommended actually from one of the psych journal, that probably keep an eye on how much social media you are consuming yourself. It impacts our mood and creates false either the positive or the negative impact on your mood. Consider disengaging from social media. Don't just read the headlines. Probably as a physician, it's our goal. We should be the guardian angel of the information what we put in our social media. So before posting anything what we read, probably read beyond the headline and see, is this something, try to critically appraise what's been written in the social media, rather than just copying and pasting and putting it on the Facebook. Because people, the community look up to physicians, and this has been very important, that even in our situation, and even so more important in India. Try to be very cognizant what you put in the Facebook or WhatsApp, and try to keep an eye on what you read from Facebook and what you get out of the article. And of course, do not spread the information until it's confirmed and you know for sure this is gonna be something of benefit for your social media network. So this has something that has constantly been part of our pandemic life in last few months. So that's something I just wanted to bring up. With this, I think this is the end of talk. This is our hospital here. This is the new building what we have, and these are the different sections of the hospital in University of Oklahoma Health Sciences. Thank you very much. I appreciate everybody being here.
Thank you, Dr. Bhardwaj. You have explained it so well. And I'm very proud of you that you are very much concerned about India. So thank you very much. And anybody is having any questions, please come forward to ask any question.
So I can actually read in the chat, I think, chat section from PK Doc. And I think the question is, a drug which no one mentioned in the webinar and is most widely used in India is doxycycline. I think the question is about whether it should be used or not be used. From my infectious disease standpoint, I would suggest that doxycycline is an antibiotic, which means it basically is used to kill bacterial pathogens. Coronavirus is a virus, so I don't see a correlation there. We haven't seen any studies highlighting role of doxycycline in COVID-19, so I would suggest not using it. We already know that antibiotic resistance is a major problem globally, but more so in India because of the rapid antibiotic use by pharmacists and people doing self-medications. So I would recommend against that.
So I request Dr. Malay Sarkar, sir, you are there. Sir, I welcome you. Dr. Sarkar. So I think then we will wind up this session. Dr. Sarkar is not responding. Maybe he is somewhere busy. So thank you very much, Dr. Anubhav and Dr. Bhardwaj. Thank you for your nice
Sorry to
presentation.
interrupt. Dr. Sarkar is typing that he can hear. So I think maybe he's on the call.
Okay. So we can wait. Okay.
That being said, since everybody is still here, please feel free to reach out to us. There are phone numbers are there in the beginning. Dr. Kanwar's number is towards the end. Please, we will do whatever we can in terms of if you have any patient question, if you have any ventilator related issue, the antibiotic related question for Dr. Kanwar, we will be more than happy to help out as much as we can. We are in it together. It's a global thing. It's not just India right now. But please, we just want to urge everyone. Please reach out to us. We will be more than happy to help out in whatever way we can.
Hello.
Hello, sir. Sir, you're welcome. Hello.
Thank you for giving this opportunity. I would like to first congratulate Dr. Anubhav and Dr. Himanshu. Both are our very, I would say, the most favorite students. And I really feel very happy that they are doing so good. And they still have some, attachment with the alma mater. And
Yes,
Anubhav,
sir.
every time he comes to India, always he makes a point to, contact me, and he tries to, find out as to how the IGMC is doing, how my department is doing. And I have also shared in the HODs group that Dr. Anubhav is very passionate in pursuing research. And unfortunately, he did not get the support from the IGMC. So I think this is very, very, the COVID has provided us this platform, this kind of online meeting with our students all over the world. And we should, I think, explore in future, both in teaching as well as in the research. Can we do some kind of collaborative research which are relevant to our context? I think, they have the resources and we have the clinical problems. I think this kind of opportunities and platforms should be definitely they explored for future, this kind of teaching activity or in the research activity. So I would just say, I have one comment particularly to Dr. Himanshu, that I'm also involved in this COVID care for last few weeks, ever since I have been made as a COVID in charge of IGMC. And I see a number of patients who are basically admitted in the tertiary care in our hospital. Some of the patients have very, very low saturation.
Sorry, I lost you there.
Hello.
Now I can hear you.
Yeah. So some of these patients have very low saturations and they are on high-end oxygen delivery devices. And our main issues are two. Basically, one is the oxygen supply. It is not supplied at a particular desired pressure around the clock. Sometimes there's a fluctuations. But you have basically touched upon from your pulmonary point of view, because it is very, very well known that some of these patients who are critically sick COVID patients, they have additionally cardiac involvement. You see the myocarditis, LV dysfunctions, they also contribute to the hypoxemia. So what is your experience in patients who are not responding to the adequate oxygenation through various devices, and in spite of adjusting the ventilatory parameters to the optimum level? And any role of diuretic therapy, inotropic therapy? And I think there is definitely, we should think of estimating the pro-BNP, which is a basically marker of increased filling pressures, especially the people who have in the elderly population, those who have baseline cardiac disease or those who have hypertensives. And these could be also contributing factor. Unless you take care of pulmonary congestion because of hemodynamic compromise as a result of LV dysfunction, probably this purely, the COVID-directed therapy may not help us in improving the oxygenation and outcomes. What is your take on this?
So again, going back to the basic ARDS management, if you look at the ARDS net guidelines, the guidelines on the management of these severe ARDS in terms of the fluid management is that conservative fluid strategy is preferred over the liberal fluid strategy. So that being said, the outcome of this conservative versus liberal fluid strategy, conservative means you either try to diurese these patients or you don't let them fluid overloaded over the several days in the ICU. And the liberal one is you just let them get IV fluids, the enteral nutrition, and let them in the positive fluid balance. The trial results were the patients who were in the conservative strategy, they were extubated around 48 hours earlier than patients who were not in the conservative strategy. But there was no mortality benefit, and this is any ARDS, not just COVID. And for COVID specifically, I don't think we have any specific data. So rather than creating new hypotheses, my take always has been what we know from our standard ARDS management, or in terms of any like septic shock or any management. Don't treat COVID as a entirely a new entity. Just stick to the basics, and that's what we have been doing. That we try to use the conservative flu strategy, and what we do in ICUs, in our ICUs, for these severe ARDS patients, very hypoxic, we try to measure their intakes and output very closely every 24 hours and try to keep them at around 500 to 1000 cc negative fluid balance, as long as their kidney function doesn't get deteriorated, by giving them intermittent LASIK boluses. This becomes even more important when we check the BNPs. As you said, some of these patients can have cardiac dysfunction. The guidelines, actually, the NIH guideline says you don't really need to look for echocardiogram. You don't really need to look for troponin elevations to define that cardiac dysfunction. So what the BNP, pro-BNP, it's a very easy test. It gives you a good idea about the fluid status of the patient. So if we see higher level of BNP, that gives us even more confidence that this patient will need diuresis. On the opposite spectrum, if we see COVID patients in severe ARDS and the BNP is normal, low normal, we try not to diurese them just because eventually it's the ARDS causing the congestion in the lung, not the fluid overload. In my experience, if we try to do that in those patients, we end up causing renal failure. And when these sick patients develop renal failure, that's around 20% increase in the SOFA score, 20 point increase in the mortality in the ICU setting. So that's what we have been doing. So if the BNP is high, try to diurese. If BNP is not high, try to not overload them with the fluid and just keep the euvolemic status. That's what I've been doing.
I would just like to add on what you have said, that COVID is a disease which basically affects the lung, as well as in some patients, they may also affect the heart. So when you have cardiac involvement, for example, myocarditis and LV dysfunction, fluid management is just one part of that. You see, you try to maintain the lower filling pressures because the capillaries are leaky in the lungs, right, so that it can add to the problems. So apart from the fluid management, I think it's equally important to treat the heart failure, because heart failure is not basically diuretic therapy. So we need to basically work on using these, like, for example, the RAS inhibitors, maybe small dose of beta blockers as we treat for the acute heart failure. So there may be some patients where we may have to use the inotropes if there is a severe LV dysfunction. So therefore, my take on would be that we should not purely think that the hypoxemia is primarily contributed by the lung injury. There would be some patients where it could be because of associated cardiac disease. So I think BNP is a very, very reasonably, I would say, reliable marker to assess the associate involvement of the heart. And apart from the fluid management, maybe because of restriction of fluid or maybe use of diuretics, and it is equally important in those patients, preferably if it is possible, to do the echocardiography also to see how is the global function. And then you'll have to specifically address the problem of heart failure. Then and only probably we'll be able to salvage some of these patients. Otherwise, they would have, the hypoxemia will cause further worsening of heart failure. Heart failure will further add to the problem of pulmonary congestion. And this will lead to the vicious cycle, and patient will have the adverse outcome.
I would add another thing, troponins. The mild
Yes,
elevation of troponin will happen in the myocarditis, but it's not very common. Less than 5% patients in ICU with COVID will, unless you guys are seeing more than, because it seems like even the black fungus wasn't that common, and there's so many cases there. But less than 5% in our population here, the myocarditis rate.
but we have not, frankly, systematically evaluated what is the prevalence of cardiac involvement in patients with severe hypoxemia, because I've started this in this last, as I said, a few weeks only. I was just thinking seriously, because I see lots of patients with severe desaturation on NRM high flow rate. Some are on NIV. In our center, we are not really doing the active mechanical ventilation. So I was just wondering, because if you see the pathogenesis of hypoxemia, it is basically the leaky pulmonary capillaries, alveolar edema, as well as this element of mucus plug formation in the small airways also. And there may be element of microthrombi formation in the pulmonary capillaries, as well as the cardiac involvement. So we need to have evaluation of all these three areas, see the markers of the filling pressures by way of measuring the BNP, maybe D-dimer level, just to see any component of a possible component of microthrombi formation. Of course, the prophylactic the thromboprophylaxis, they are getting the heparin, but there may be some patients where desaturation, probably it would be very difficult to rule out the element of pulmonary embolism also. If the saturation is not improving, I would seriously feel that we may have to use the therapeutic dose of the anticoagulation in addition.
Yes.
Just going to add one more thing quickly. I also feel that in Indian population, the heart disease is probably undiagnosed. And I think COVID-19 is a perfect situation for it to get manifested. So that may be one of the reasons why, there may be difference in the Western population where we are not seeing that much of myocarditis versus, higher cardiac dysfunction in Indian population, because there is baseline heart disease, baseline cardiac involvement due to other comorbid conditions which has not been undiagnosed.
May I come in now?
Yes, sir.
Hello. First of all, congratulations to both of you, and both of you explained the topic and touch all aspects and in a lucid way. I hope everybody would be benefited. You rightly said the bacterial infection is not so common, unlike the bacterial infection happening in influenza, where 33% develop bacterial infection. Here only 10%, that too in the later part. But antibiotic misuse is extremely rampant, and not only cost, it will also create a MDR pathogens and also drug interaction. But I have one query. Sometimes the COVID pneumonia also produces, dense consolidation, and procal level can also be high in COVID pneumonia. So is there any way by which you can identify the bacterial infection in patient of COVID pneumonia?
Yes, so I can quickly answer that. So I wanted to touch base on that, but because of the time constraints, couldn't do that. So procalcitonin is a good marker for bacterial infection, especially for lower respiratory tract infections like pneumonia. So I think in COVID-19, we have to use it judiciously. So we could use a cutoff of 0.5 nanogram per ml. So if it is less than that, and patient does not have classic signs and symptoms of bacterial pneumonia, we can safely conclude that this patient does not have bacterial pneumonia. It seems that the procalcitonin has a high negative predictive value, which means if the levels are low, it can safely exclude the possibility of bacterial pneumonia. Now, COVID-19 is a systemic disease. It involves multiple parts of our body, including our gut, where there is also production of procalcitonin. So higher levels of procalcitonin are not beneficial in ruling in or ruling out bacterial pneumonia. But I think if the levels are less than 0.5 and clinically patient does not have signs or symptoms to suggest bacterial pneumonia, we don't need to use antibiotics.
Well, thank you.
And let's comment about it.
Yeah, sure.
Yeah. So here's what we do, and it may not be possible exactly there, but pneumonia, it's a diagnosis of imaging, clinical features, and the secretions. So 3 components.
Right.
If you have intubated patients, and if we see a fever which was not there before, patient was afebrile, and you see a fever within like being afebrile for 2-3 days, and then there's a new fever that starts up, secretion starts getting more purulent, and then of course as you mentioned, there's a consolidation. Yes, that's a very valid indication to start the empiric antibiotics if possible. Not I know it's not possible in every situation. If patient is intubated, what we do in our center here is we start the antibiotic, and right before we start the antibiotic, we do a BAL, bronchoalveolar lavage. And
Right.
what that does is you cannot stop the antibiotic usage, but you can stop the antibiotic usage much more faster. If the BAL negative results come negative, or they can sometimes even show a pathogen which is very sensitive, you can actually de-escalate the antibiotic therapy much more quickly. And that I think will apply to sputum cultures too in the same way. That that's not as good as BAL, but probably at least help in that way too.
Well, I have the second question. Like as you have said that you should wait at least 6 weeks after discharge for deciding the role of steroid for 4 to 6 weeks period. But I have one query that if you wait and then there is more chance of fibrosis, right? If a patient having 22, 23 score, should he start when the patient having ground glass opacity at the time of discharge and he is not maintaining oxygen? I mean the antifibrotic therapy along with the steroid. And secondly, we prefer here the nintedanib over pirfenidone. Only one reason, because if you look at the IPF trial, where the both the curve, the Kaplan-Meier curve, they start separating in case of nintedanib around 4 to 6 weeks, where it happens around 3 months with pirfenidone. So because of that reason, we are using nintedanib rather than pirfenidone. And your take on this? Should we start early or should we wait 6 weeks?
So, Dr. Sarkar, the reason why this 6 weeks time, if you look at the, it's in my presentation too. I can send you the article too. The most recent, it was an observational study from Annal of Thoracic Medicine, ATS, and in that, only 35 out of 800 patients developed the fibrotic changes like the at 6 weeks. So patients, 800 patients had ARDS, and at 6 weeks, only 35 of them they developed the fibrotic changes. So that means around 750 of them they recovered. So
Right.
if you generalize this therapy to everyone, you will end up giving steroids in that trial. I'm just giving an example to 750 patients who really did not need steroids. So the recovery rate is so erratic that probably less than 3-4% of them, they are developing these fibrotic changes. So that's probably why they are recommending this 6 weeks, because just to make sure you don't end up overdosing everybody with steroids. So that's I think the reason for this 6 week time. And talking about the antifibrotic therapy, actually we are not using antifibrotic therapy, neither the pirfenidone, neither the nintedanib for this population. No trial. There are trials going on, I know that. And I think one of my colleagues is actually trying to enroll patients in one of the trial from Boehringer. But this is not been studied, not been recommended. The problem with these antifibrotic therapies, these are lifelong therapy in general, right? So I have no evidence supporting that you can give 3 months of that and prevent some the fibrotic changes. So at least in our center, and I'm sure pretty much all throughout country here, we are not using the antifibrotic agents.
Right. And I have the another third question, that is, you have said that all kind of oxygen device, they can disperse the aerosol particles to different extent. So when you are using face mask, you should also use a surgical mask over it, I mean, when you are giving oxygen through face mask, you should use a surgical mask. But where should be the location? Should you put the surgical mask first and then over which you should use the oxygen mask, or the reverse way? Because there is one study I remember from Australian Journal of Anesthesia, where they have shown that the oxygen improvement is equal whether you put the simple face mask over surgical mask or surgical mask over simple face mask. And your take on it?
So for the face mask, I haven't seen that study, Dr. Sarkar. But for the face mask, we actually, when we are using face mask for oxygenation, we actually don't put any like a surgical mask on top of it. And I think the part of the reason for our practice here is that at least in the ICUs, these are all negative pressure rooms we have.
Right.
And that may be different there. So I cannot comment for or against it. I probably have to look at the more data. But in our practice, we haven't been using the surgical mask on top of the face mask.
Okay, thanks. And just one comment, Dr. Anubhav said about the doxycycline. Actually, initially we started using it, and most of the center in our country, because there are few studies, one from Bangladesh, which has shown benefit, the combination of ivermectin and doxy. At that time, we didn't have standard randomized control study to support it. I agree with you on that point. So that time we use the same guideline, like ivermectin and doxy. The doxy was used not as antibacterial, but it was used to reduce the inflammation, particularly intercellular inflammation. And probably that's why it was used in the Bangladesh trial. But now we have evidence that we don't have strong evidence for or against using ivermectin. So maybe in future ICMR will change the guideline. They will not recommend ivermectin too. And we have changed the guideline recently in our state. We are not now recommending doxycycline. Just recently, we have revised the guideline. We are only using ivermectin for mild cases.
Yeah. I think there are excellent clinical questions, and I think it kind of opens up that there is a lot of potential for research studies. I think the way US and other countries, they have dealt with pandemic is to study these treatments. So I would encourage that if there is an interest in physicians, in IGMC and or maybe TANDA to start a clinical study. I think that's the best way to do things in our own population, because there are genetic differences in how we metabolize medications and our immune system. So what we have studied in the Western world may not apply completely in the Indian population, which again, I think we need more data. So I think there should be some type of studies, IGMC being the premier institute in Himachal. I think we should, this is a perfect opportunity of studying new treatments which have potential of improving life or mortality at a very low cost.
Right. And lastly, I would request you that if you are interested for any collaborative project, you can send your proposal and to the respective department, and definitely we would be the most happiest person to do collaborative project with both of you.
Yeah. One thing which comes into my mind very quickly is mucormycosis. So I think I could really help. I really I'm passionate about infection control and outbreak investigation. So we could actually do a case control study of any mucormycosis cases that are being diagnosed at IGMC, as to find out what are the risk factors which led to them to acquire mucormycosis. Alternatively, we could launch a environmental investigation where we could sample different parts, maybe the humidifier solution, maybe the surroundings of the patient, things like that. And I think if we find environmental sources, that would be a way of connecting the dots and seeing if patient got mucormycosis or not. So something of that sort I would be very interested in. And after this talk, we could probably correspond on coming up with a potential proposal on how to investigate mucormycosis cases in Himachal.
Thank you so much. And I would request both of you that whenever you get time, you want to do webinar on any topic of interest related to infectious disease and pulmonary medicine, you just let me know and we will do it for the state, right?
Absolutely.
Sir, I am a primary care physician, sir. Thanks a lot for a nice presentation, sir. We have learned a lot of data and clinical knowledge from ivermectin and doxycycline. Sir, could you please elaborate the sufficient data whether it's used in a combination, because still we are using these drugs in a peripheral care setting.
Sure. So ivermectin is traditionally an anti-parasitic drug. We use it for treatment of many parasitic infections. Initially, there was a thought that it might reduce the viral replication and binding. But in a clinical trial, which was a randomized clinical trial done in South America, they did not find that it actually leads to earlier clinical recovery or leads to any mortality benefit. So here in the US, we don't recommend it. I think in India, ICM are still recommending it, but we really do not know if there is good data to see if it works or not works. And doxycycline, we know that it's an antibacterial. There is some concern or some hypothesis saying that it has some anti-inflammatory properties similar that we thought for azithromycin. But in clinical studies, we haven't seen that translate into clinical benefit, whether it is earlier clinical recovery or mortality benefit. And instead, we have seen higher rates of resistance to, say, macrolides for azithromycin and for tetracycline with doxy and other side effects. So personally, I would not recommend using any of these medications in a patient with COVID-19 unless there is a concern for bacterial infection. Now, I do want to highlight quickly about ivermectin. Many of our population are, they have worms, they have worm infection due to strongyloides. So ivermectin could be prophylactically used in patients who have past history of worms if they get steroids, because steroids can lead to hyperinfection syndrome due to strongyloides, which can again present like ARDS and disseminated disease. So
that's
prophylactic
one-time,
ivermectin could help in those cases.
Thank you, sir. Thank you.
One interesting finding, I came across two studies where tocilizumab reduces the blood sugar level. So what's your take on tocilizumab and the recent surging of mucormycosis in various parts of the country? So because it reduces high blood sugar level, that there are two studies supporting these.
Yeah, I'll have to look at that data specifically on what is the percentage reduction in the blood glucose. I can take example of my patient that I took care of with CDC. He did receive tocilizumab. So I think it's a combination of factors which make us predisposed to fungal infection. So I think it's COVID-19 itself, which has lymphopenia. Tocilizumab is an interleukin-6 receptor inhibitor. So it does curb down the inflammatory response. And then certainly steroids, when they are in combination, and especially if patient has baseline diabetes, I think that's why we are probably seeing higher cases. I do want to emphasize that there's lack of infection control and lack of proper investigation into study the role of humidifier and humidifier solutions in these mucormycosis cases. So I think we need more data. There are host factors and there are other factors, which is the environmental factors, which I think both are contributing. But we need more data from case control studies and outbreak investigations as to, because we didn't see this in the US. We have diabetes here. We have tocilizumab here. We did see, I would say, rarely like 6 or 7 cases, and that was in February. Maybe there are a few more cases after that. There was increased aspergillosis. So there was a term called COVID-associated pulmonary aspergillosis, or CAPA, that has been seen. but we haven't seen much mucormycosis here. So I think there is also something in the environment in Indian hospitals or in in the general environment, which is probably responsible for increased number of cases.
Actually,
The other problem I think is the blood sugar control. So with the steroids, in my best guess, I don't think we are watching blood sugar very closely. So I'm pretty sure the patient with pre-diabetes or mild diabetes, their blood sugars are running in 300, 400 consistently while they're on steroids, which can be very easily tackled just by using NPH temporarily for a few days. So I think that's definitely adding on to the pandemic or pandemic within pandemic of mucormycosis. When we use steroids, I would suggest be very, very careful how the blood sugars are responding. Even if patient doesn't have diabetes, with pre-diabetes diagnosis, their blood sugar will start running very high, and controlling that definitely will help in at least decreasing the risk of mucormycosis.
Well, but we are using steroid for so many rheumatological condition in our country, right? Even quakes are using steroid for any fever in the rural India, but we have never seen such a surge of mucormycosis. So probably another reason could be the lymphopenia that this COVID patient developed. That may be another reason, right?
Yes, yes.
That's probably is adding on to it.
Yes.
So
Hello.
any more question? Yes.
Yeah. Hello, Dr. Malloy. So first of all, really nice to see Anubhav, and it's Dr. Praveen here, Praveen Bhardwaj.
Dr. Bhardwaj,
really nice to see Anubhav and Himanshu. It was great to hear both of you. I actually joined a bit late, so I could hear the full presentation of Himanshu. I couldn't hear Anubhav a lot, but then I will definitely see on the YouTube, the link that was sent by Dr. Sarkar. There's one more additional problem, especially in Himachal. We are a hilly state, and this we have seen for last about 15, 16 years since we have started our pediatric intensive care unit here in IGMC. And we realized that when compared to plains, at height now, Shimla is at 7,000 feet, right? So barometric pressure here is 580 millimeters of mercury. So definitely a mild hypoxemic failure for plains will be moderate to severe in hills, because the 502 is even 580, so about alveolar is somewhere about 100 millimeters of mercury, right? So one thing more important is about what Dr. Sarkar said about steroids, as why mucormycosis is more. The other reason I think is because we're using very heavy doses of steroids, while in rheumatoid or in other diseases, the steroid dose is less, so we are decreasing the HPA axis, so shock will be more, and in the post-COVID phase as well. So whenever the patient comes, has taken steroid for about 6 days, more than 6 days, we should also consider where the HPA axis has gone down, so cortisol level should be checked, and these people can present in shock, and we are treating for other things, and we're missing the shock as well. So that is one. And secondly, we are using mostly humidifiers, and we are using just tap water, not the distilled water. So if you're using these humidifiers with simple water for a longer period, remember that contains organic matter, and that's also a source for fungal infection. And that's what we see in our NICU here, in newborn unit as well. And that we are seeing for not now, we are seeing it for a longer period, the fungal sepsis. Because when you have a prolonged person on ventilator or on oxygen delivering devices, the humidifier should always contain distilled water. And that's I've been, after so many times, I'm telling the medical superintendent for every humidifier device, you should have distilled water rather than normal tap water, because then organic matter is there and fungal infection is more. So one more thing is that when we wean off the patient, because at a height of 7,000 feet, as you know, for every 2,000 feet, the minute ventilation increases by 5%. So if the patient, for example, is weaned off from oxygen, so one is weaning is delayed here in Shimla. For example, in plains in Chandigarh, it will take 5 to 7 days. Here it will take 8 to say 15 days to wean off someone from oxygen because of the height factor. And after that, if the patient moves to another height, for example, from Shimla, he moves to Narkanda or say to Kinnaur, he will be again hypoxic because he has been weaned off at 7,000 feet. He should not move upward from the 7,000 feet. And that is one thing which is missing basically, I think, at least in our hilly state, the Highlander studies are less. So I think if any one of you can say something about that as well, because whenever you have ventilation perfusion mismatch with damage to the pulmonary capillary membrane, as happens in inflammatory damage or the ARDS that we deal with, I think here we target the minute ventilation to 125%, or say 90% of that. That turns out to be 100%. So any take on that as well? And second thing is about the humidifier, use of tap water for humidification of the oxygen delivery devices. And one thing we are missing, just one more, Anubhav, that we are dependent mainly on oxygen. So oxygen, if you are requiring FiO2 to more than 50%, definitely nothing is going to happen till you recruit more lung. Once it is persistent hypoxemia, that is, if FiO2 is more than 50%, then even if you make it to 60%, 70%, nothing is going to happen, because now you have to recruit the lung which is already collapsed. So that is where you come with NIV and invasive ventilation, which obviously is difficult in this place because a lot of people are not trained in invasive ventilation, except for anesthetists and pediatricians here in Shimla. So I think we should go more for HFNC, because HFNC, one, it provides high flow, and second, it also provides some PEEP as well. So HFNC should be the, I think, mode of a device that we should be using in our country more than we are placing so much of order for ventilators. So even if we have 60, 70 ventilators, we don't have the people. And ventilators, positive pressure ventilation is a detrimental kind of modality if you are not monitoring the patient. It can cause more harm than benefit if it's just put on and monitoring is not there for 24 hours. And since we don't have that much of staff, and I think HFNC is the one which should be promoted more in our setup.
So
you are taking
Dr. Praveen, as I mentioned, it's not the ventilator, it's the person behind the ventilator that
absolutely that's what I want to say.
Yeah. So that being said, what we did, which I think should be a consideration, we had a one-day workshops for physicians who already had good experience in medicine part. They just did not have good ventilator experience. So what we did 1 day, and all we taught them was a simple assist control volume cycle ventilation. That's all we taught them. That's it. Nothing else. There's nothing. We told them, this is what you need to do. There's anything else you need, you will not test the ventilator beyond that. If something else needs to be done, you will reach out to them. And then that the intensivist, or it can be anesthetist, it just has to be a person who knows how to handle the ventilator. And because most of the time, 80% of the time, you will do okay on simple ACVC. 20% of the time, you will need tweaking, which will need expertise. So in that way, what we did is we had several people who knew at least how to do the basic functioning. And then for those 20% circumstances, when they were tweaking needed, they will reach out to that. And at least that way, the intensivist wasn't seeing all 100 patients. He was only being called for 20 patients who needed something beyond that. And then there was a protocol. We did plateau pressures. Everybody was taught on that. And everybody got blood gases in the morning. And in the round, everybody. So that was the fail-safe mechanism. And especially in our hospital, where we have 16 physicians in my section, and there are almost 30 anesthetists in my hospital. So they are all trained in and talk about all the cardiothoracic intensivists. So we have a lot of people, and still we had to go through this. So I think that would be my suggestion, that simple medicine residents, they can be taught about basics in 1 day. It does not take more than 1 day. And then you can deal with that, because with high flow, non-invasive, you can only go beyond so much. You will end up needing ventilators at some point.
That I think Dr. Malloy and myself, we had taken about so many webinars on ventilation, and even demonstration as well. But people, those who have never worked on ventilators, they are basically shy of using it. You're absolutely right. We do have people in anesthesia, in medicine, they can be trained as well. But the overemphasis on oxygen and venturi mask, and then less of HFNC. I think they should be more.
Yes,
At
the
least
HFNC is
minimum
actually
support.
the, yeah, definitely. HFNC in even my talk, NIH recommendation in our country here is HFNC should be preferred way even more than the NIV.
Yeah.
So, and it doesn't need any expertise. It's just FiO2 and the flow. These are the only two things you need to handle.
Yeah, yeah.
As far as
So
the
once again,
humidifier question, Dr. Bhardwaj. So I think we could just do a simple test. Let's just send samples from tap water we have. Let's just send it to microlab. I mean, say we will know. That's very simple thing. The other thing is, I don't know if we have ROs, reverse osmosis systems in hospitals, or normal saline. I mean, so we should probably use that. Those are not very costly. So I think they could be easily procured. But I think what we need is a good case control study where cases, and then we have
we have a lot of studies from pediatric side from India, where they have shown that if you use routine water in oxygen humidifiers, then incidence of fungal infections are more in most of the PICU and NICU settings, and they're not using it anymore in higher institutes. Here we get often on, the requirement will be very high, so there are about 500 oxygen points, So I'm talking to the people as well from such a long time to have just distilled water use. We can have cans of 10 liters for every ward.
Or even if we could just boil water, and then that boiled water could be cooled down. I mean, it's more like an engineering issue or logistics.
Sometimes many residents of ours ask for mineral water for that, for our ICUs. We have only so to boil it will be very cumbersome.
Yeah, so I think just saying it's just more like a logistics or an engineering issue to do that. But I think we could confirm that by just culturing tap water. We do know that tap water has a lot of mycobacteria. We do see a lot of mycobacterial infections with tap water use in immunocompromised patients.
So I've been advocating for a bigger ICU for last 10 years with all the stakeholders for such a long time. I think COVID definitely should open up eyes that we need a very good ICU support at our place now. I think
we need
that's what COVID is teaching us now. Yeah.
As far as hypobaric hypoxia, so we did a study when I was medical student. We looked at the impact of hypobaric hypoxia on hypertension, blood pressure, and other parameters in natives of Spiti Valley. So we looked at patient natives living at 3,500 meters in Spiti and then at 1,800 meters. What we found was that people who are living at 3,500 who were natives, they already had changes in their genes, as a result of which they could extract more oxygen because they have been living there for so long. They had excellent adaptability skills. So they did have a low prevalence of hypertension, even though they had risk factors. Like they were drinking salt tea. They had more risk factors, but despite that, they did not have hypertension because of the genetic changes. So I think I agree with you that there's certainly a concern for acclimatization, and then we should interpret the guidelines very carefully. Actually, the NIH guidelines say that severe COVID is defined as less than 94% on room air at sea level.
Absolutely. So, at sea level, that's what I understand.
So I think we do need that modified. We need actually more data on what is considered normal for high altitudes.
Yeah. That we are doing a study, but we are doing in neonates, basically, for neonates with PPHN, persistent pulmonary hypertension. So we have found that when we shift them to a lower height, for example, in Shimla, it takes about 20, 25, sometimes for 1 month to taper them from oxygen. But when we shift them to a lower height, for example, at Nahan or Mandi, if they can go there, their oxygen is gone within the next 2-3 days. While in Shimla, they were persistent, with only 0.5 liters of oxygen from 60% at room air to straight away 90%, showing the pulmonary reactivity, basically, with no fixed defect in the heart or any lung disease. So height definitely makes a difference. And when you are dealing with the patients who got respiratory and cardiovascular compromise, even if they are acclimatized at height, still in those diseases, the height will make a difference, and their hypoxemia will be much more worse than if they are living at lower heights, which obviously we are at a Highlander Institute. So we definitely get severe hypoxemias here as compared to planes maybe. So most of the studies are from planes. And that's the reason why we are requiring a lot of oxygen, and people are on oxygen for a longer period than maybe in Delhi or somewhere else, like in Bombay. So thank you very much, both of you. It was really a proud moment for all of us, I think, here in Shimla to see both of you and doing very well. Whenever you come, so definitely do visit, and it will be really nice to meet you both. Okay.
Thank you, Dr. Praveen. Thank you very much. All right. Thank you, everyone. I guess we are done, right?
Thank you, sir.
Questions?
Hello.
Dr. Sarkar?
Yes, yes. I have one question. This is the last. This is my last question. Okay. Steroid misuse is so rampant, and even people started using steroid from the first day. So I just want to know if a patient who comes in the initial 1 week with hypoxia during the viral replication phase, will you recommend steroid during that phase or not?
I would. So even though the trial was after, I think, 6 days or so, but it was hypoxia-based enrollment, Dr. Sarkar. So in my opinion, not everybody follows the book. So sometimes, and a lot of the time, diagnosis is delayed. So instead of having the hypoxia 6th or 7th day, sometimes you will have the hypoxia even earlier. So in that context, I will use steroids not more than 6 milligram, even with the early hypoxia. On the opposite spectrum, I will not use steroids, even if your chest X-ray shows 100% or CT score of 30 and you are not hypoxic.
Right.
So it has to be clinical. If you are hypoxic, I think you should use steroids. If you're not hypoxic, there is no role of steroids. Doesn't matter how your X-ray looks, doesn't matter how your CAT scan looks. Or we have been using, I saw that in India, the lot of CT scoring, we have been using CT scoring of 29 and worse. Actually, the guideline says there is no correlation. So there no management decisions in terms of steroid usage or remdesivir usage. Any management usage should be made based on these CT scoring or based on these imaging.
Exactly. And we are telling the same thing to during our webinar. They don't advise unnecessary CT scan. And even I remember one study from New York, which is probably retrospective study, where they have shown that if you use steroid in a non-hypoxemic COVID patient, there would be even chance of mortalities there.
Oh yeah. That was actually the trial from recovery trial. One of the arm, I think, when they used it, there was a trend. It was not statistically significant, so that's why it never came to the news that much. But there was a trend, a clear trend, that if you're using non-hypoxic patient steroids, there's a trend toward mortality, and that's another reason we should not use steroids. That's the thing. I think if you use whatever evidence-based is and don't go beyond that, it's a very spine slippery slope. And if you go anything beyond one way or the other way, I think you are running in a murky grounds, and the chances of falling and chances of causing harm is more than causing benefit in that situation.
Exactly. And thank you very much. Thank you, both of you. And hope in the future we'll have many such meetings and from both of you, right? And
absolutely,
of course.
Thank you. Good night to everyone.
Good night. Thank you.
Thank you, Dr. Sarkar. Thank you. Thank you, everyone.
So thank you, everybody, to be with us for this webinar. Thank you, Dr. Anubhav, and for Dr. Bhardwaj, and of course, Dr. Malay Sarkar. Thank you very much. I wind up this session. Thank you.